A very pleasant good morning, everyone. Hello.
Good morning.
All right, I'm not seeing everybody online, but I'm going to start nevertheless because I understand that you have an engagement later this morning, and I don't want to run into that time frame for your other class or engagement that you do have. And I don't plan to be with you long. 20 minutes maximum is what we should spend here prior to. So the meeting this morning is ready to look at a disaster preparedness workshop that is scheduled for next week. We have been having some challenges in terms of finalizing the schedule, and Hurricane Melissa is being blamed for everything. So I'm wondering in my mind to what extent she has something to do with the challenges that we have been encountering in pulling this workshop together, because we have never really had some of these challenges before. Just to say to you that there are some of my facilitators who are the staples on the plate for the delivery of this workshop. Some are off the island on duty travel. Others, because of work constraint, may have to defer their presentation until next week. So I want us to get that clear. It's not that we're having 2 weeks of workshop, but we are having some challenges this week with some of our facilitators who are otherwise engaged because of work-related matters. We try to get facilitators who are of the highest caliber in terms of the experience and expertise in their field so that you can get the best of the best, so that when you go, you know that you are well grounded. So starting on Monday, we are going to be kicking things off with disaster preparedness and ODPEM, and they will be coming in for the first two sessions, which should have started at 8:30 and would have ended at 10:40. After we are through with ODPEM, then there's a 10 minutes break, and then we would come back to be joined by Jamaica Fire Brigade, and then we have Jamaica Council for Persons with Disabilities in the afternoon talking to us about how we manage persons with disabilities. How do we empower them to? Because they are a part of the population, and often when we plan things, they get left behind. But we really need to pay attention because they're a very vulnerable group. After lunch, we will be having PAHO, somebody from PAHO looking at food and nutrition in disasters. 3:40 to 4:40, we would have been having Red Cross coming in. However, so far we have not gotten a confirmation, so we may not have that session on Monday. Monday evening, we need to have a session from 7 to 9 o'clock. And the reason for this is that the facilitator for that particular session, which is scheduled for Thursday, will not be able to meet with us at 3:40 to 4:40 because of work constraints. And so he has offered himself to be available for 7 to 9 on Monday. So you might be asking, so when we go up so late, what happens is we started from in the morning. The good news is that we will not be having any sessions on Friday, so that we should make up for all the other extra time that you may have had to put in, for example, for Monday in that late session in the afternoon or in the night. So Friday is going to be free. No sessions are being planned for Friday. So we are just going to try to get everything done within those 4 days. The session that was scheduled for Tuesday with mass casualty management, which would be done by the representative from the Ministry of Health and Wellness, Dr. Dawkins Wright will not be able to do that session on Tuesday morning. What she has said though is that she is available to do that session on the 28th in that same time space. And that was the reason why I would have asked Jody to find out from the class whether or not you have any engagement for Tuesday at that time before I give her final feedback. So I want to ask that question now. Can we have that session next week, Tuesday on the 28th between 8:30 and 10:40? I need to
Hi,
hear.
hi, Miss
Good
Walters.
morning.
Good morning.
Autos. Would this be online or face to face at 8:30 on the 28th?
Online.
That's good for me.
Okay. This
Yes, go
that
ahead,
should.
Alex.
I was just going to ask the same thing that Shelly just asked, but it's confirmed that it's online, so yes, we can make it work. Um,
Okay. So that would be next week, Tuesday. No, I'm sorry, the 28th. Also, the person who has been asked to do the role of the media in disaster, which would have been scheduled for Thursday at 11 to 12, is not able to do it on that day, but she would have been happy if we could schedule her for the 28th for that same time spot, 10 to 11 to 12. Do I have the class permission to say yes to her? It is possible.
Yes.
I just want to know, because
Again, Miss Walters, is that one going to be online or that one is in
yes, it's
person?
online, online.
Okay.
Anything for the 28th is going to be online.
Yes, that's good, Miss Walters. So far it would be Monday and Wednesday then that we have in face next week.
No, Monday, Tuesday, and Wednesday, because we remember we have some other session scheduled for Tuesday. So just that first session. I want to send you the schedule. Really,
Okay.
really hope I would have been able to send out the schedule from yesterday. The truth be told, I am having some glitch with my computer in terms of the subscription for the platform that I use. I am shifting from an individual platform to a family platform, and I have encountered some glitch with regards to that. And because of that, I'm not able to edit any Word document, any document at all on the computer at this time. So we're working with the subscriber to get it sorted out now. So as soon as it is sorted out, you'll get the because I didn't want to send you the schedule now without the adjustment. And so I'm having that little challenge. That is why you have not seen it in your mailbox as yet. So for Tuesday now, so the first two sessions for Tuesday will not be held because that is being redirected to the 28th. But you will have at 11 to 12 o'clock the Mr. Raymond Stewart from the earthquake unit, and he's coming face to face. And followed him will be the police department. They will be face to face as well. And then after lunch, you'll have our very own Jacqueline Duncan looking at basic principles in handling chemical spills. Somebody is singing for us. On Wednesday, we most of Wednesday will be done by the Ministry of Health again, the Environmental Health Department this time. So 8:30 we'll start off with shelter management, followed by vector control. Then we look at sanitation and water supplies, then food safety. And all those sessions will be done by personnel from the Ministry of Health and Wellness. And they have indicated that they will be with us face to face. There was a session that was scheduled for 2:30 in the afternoon on Wednesday to look at information management and communication. The person who normally facilitates that session is not available because she is otherwise engaged next week, all of next week, with another workshop that she has responsibility for. And to date, I have not yet been able to find a replacement. So that session right now may not be held at that time. On Thursday, all the sessions on Thursdays will be online. So it's just Monday, we are going to be having face to face, Tuesday and Wednesday. All our Thursday sessions are going to be online. And on Thursday in the morning, we will start out with Dr. Roseanne Simit from the Department of Geology, looking at climate change. Then we should have veterinary public health in disasters. That facilitator is currently abroad, so she would be presenting online as well. Then we would have Mr. Stewart, coming to us at 12 o'clock. And he's also online looking at biochemical and radioactive disasters. And the session that would have been scheduled for the afternoon of that day, as indicated previously, that will be done at 7 to 9 Monday night. Are there any questions, any queries?
The 7 to 9 on the Monday, Mrs. Walters, is that online or in person? Because it seems as if most of the sessions on Monday are going towards being online.
No, Monday is more face-to-face. Thursday is online, Monday is face-to-face.
Oh, you were just saying Thursday?
Yes, we were just looking at
The
Thursday.
schedule was Thursday. Okay. So that session that you said at 7 to 9, that's Thursday?
Monday.
Monday, okay. All right, thank you.
Hi, Miss. Good morning. Not sure if I missed any information on Monday to Wednesday. Digital was having some issues, so some people didn't have surveys. This is April, just getting. So I only heard Thursday when I came on. I'm not sure if you said anything about Monday to Wednesday before that.
I did, and I'm very happy that you spoke just now about the Digicel and its internet activity. That's one of the reasons why the workshop really needs to be face-to-face as best as possible, because we are having internet connectivity issue and the kicking offline is not helping anybody. We don't have a window period where if this workshop can't happen next week because of internet issues, then we can find another day time to push it back. Primarily because 90% or more of our facilitators are external persons. So when we talk about it being face to face, I know some persons are not happy with it, but we have to look at the bigger picture. We can't just say students would prefer to be online. We have to look at the facilitators, their availability, and the fact that we are always having internet connectivity issues.
Hi
So,
again, Miss Walters. It's Melissa again. Just confirm, I guess, for April, I think it was, who just got to join. And also because you said that the emails may not come out in time with the updated schedule. So just to run through, so Monday we're starting at 8:30 a.m. and everything on Monday is online, is in person.
right.
Okay, and Tuesday you had said,
The first two sessions on Tuesday will be rescheduled for the 28th. And on the 28th, everything on the 28th is going to be online. So just make a
okay.
note of that, right?
Okay, so what time would the face-to-face sessions on Tuesday start then?
At 11 o'clock.
11. Okay, and Wednesday it's face-to-face for all the sessions
Starting at 8:30.
at 8:30. Okay, and Thursday?
Online.
Okay, everything is online on Thursday. Okay, and we have
Right.
nothing the Friday.
Right.
What time do we finish the Monday and the other days that were face-to-face?
All right. From Monday, remember we said we are going to have that late session on Monday, 7 to 9.
Mm-hmm.
But for the other days, we are expected to finish at 4:40.
Okay. All right. Thank
Depending
you
on
for the
what is, yes, depending on what is happening Wednesday and Thursday, you may finish a little earlier. Well, I know for Thursday definitely that you are going to finish. Well, Thursday is online anyway, so nobody would be in the classroom because everything for Thursday is already online. Are
Thank
there
you,
any
Mrs.
other
Walters.
questions?
Morning, Mrs. Walters.
Good morning, Nashan.
Just joining in. Totally forgot. Totally forgot. Um, can I don't know. So, did somebody take the information and will be sending it in the group in regards to each day? What will happen?
Well, your class rep is online, so I guess she will, but I really want to send the schedule out. It's just that I'm having some computer issues in terms of inability right now to do any editing on the document because of my subscription, changing subscription protocol, and it has created a little glitch that I never anticipate.
Okay.
Mrs. Walters, in light of that issue, even though we may not get like a full schedule with each component that is happening each day, is it possible to just get an updated overall schedule like we just talked about, for Candice to send that out so that
What I
those
think I'm going to try and do is to email what I have to Candice and work with her in terms of doing the editing, because if my thing don't get sorted out in short order, I mean, I'm not going to be able to do that. So I have considered doing that today, get it to her, then sit with her, do that editing, and so it can be sent out to you.
Okay, thank you very much, Mrs.
Right.
Walters.
Good morning, Mrs. Walters. I'm sorry I joined late. Just to confirm, you said classes next week is from 8:30 in the morning to 9 in the night?
No.
Mondays
Monday
8:30
alone is the only day you're
9.
going to go up to
Yeah.
9.
Tuesday we start at 11. Wednesday is from 8:30 to I think 4:30. And Thursday everything is online. So basically 2 days next week is in person. 3 days next week is in person, one is fully online. And then Tuesday is the day we start late. Nothing Friday.
Okay, got you.
Did I have that right, Mrs. Walters?
Yes, you do.
Okay, great. Thank you.
So if there are no other questions, no queries, this is where we are at for next week. And looking forward to seeing a full house as we go through.
Okay. Thank you, Mrs.
Okay,
Walters.
Miss. And refreshments will be provided for us, right, for this whole day.
I
Thank
am not
you.
in a position to answer that question because I have no idea what the financial status of the department is. So I could not answer that question. That would be getting myself into a whole lot of trouble. But I'll speak with Miss Prince and see if there's any money in the kitty and if it can suffice. But I can't make any promise where that is concerned.
Okay, no problem.
All right. So if there are no further queries, this is a brief meeting I wish to have with us so that we can be on the same page come next week and have as smooth as possible execution of the disaster. And if you think back about what happened with Melissa, you recognize the importance of this particular workshop.
Definitely, Miss.
As you go out and you become managers in your own right, some are already managers, and having completed this course, there are a lot that is going to be expected of you, and we are cognizant of that, and that is why we try to prepare you as best as we possibly can. One of the things that I tried in the past 2 years to do is to get a field visit in on the Friday where we could actually go to ADPEM or one of those other agencies and see how things happen. But I mean, I was hoping last year it never happened because they were doing refurbishing. This year, Melissa just kind of mess up everything. So I am just really hoping that we can get even a field visit in one of these thing, because I feel it
Cases.
makes a lot of difference. And I know at PEM their thing is well set up. It's really nice if I've ever been there for a seminar or so. I mean, the place is really, I would say state of the art, but it's as close to perfect as possible. And that is
Okay,
why
maybe.
we have the national EOC. That's where it is kept at
Oh, okay. So maybe if not Friday, maybe we can still arrange before the program ends. It would be a good experience.
Well, talk to Mr. Divini when he comes Monday morning, because he's a person from ADPEM who's coming to us Monday morning. I don't know if he's going to be bringing a team with himself.
Team with him. Okay.
Right, but
Perfect.
it's really nice because when the national EOC, you talk, I'm not talking about Ministry of Health national EOC. I'm talking about a national EOC where all the interagencies meet. They tend to meet
Oh,
at conference room
at
ADPEM.
PIM.
Yes,
Okay.
and it is really set up real-time information coming in and data analysis is just awesome.
Okay. As
Yeah.
part of this course next week, Miss, would be looking at what the disaster preparedness plan should have. I'm assuming. I'm just asking just for clarity. Because I know each year my parish has to send out a disaster preparedness plan. So I'm assuming it's just the same plan that they send out each year. But in the event that we go back and they ask us to do up a plan, would be able to look at what currently exists and how we can like tweak it or something.
I believe that should be covered with the 7 to 9 session on Monday with Mr. Adrian Booth, who is going to be looking at establishing emergency operations center, and he's going to be looking at it from the local level, not at a national level, from the local level. And he's somebody I worked closely with when I was working with the Southeast Regional Health Authority at the regional office. I had responsibility to make sure that all the different or hospitals and institutions submit their emergency operation plans. We go through them and forward them to the Ministry of Health. Whenever we're having a disaster, it was Adrian's responsibility to set up the emergency operation center. So even in his sleep, you can wake him and he'll tell you exactly what needs to be done. So you can pose all of those questions to him Monday night, and trust me, he's a walking encyclopedia where that is concerned.
Okay, perfect. All right. Thank you so much, man.
Is he the same one that did the tobacco workshop?
Yes, he's the same person who did the tobacco with us.
Could you ask him to send his PowerPoint from that lecture?
He didn't? Or is it that I get it and I didn't send it? All right, I will, I was scrolling through something that then I saw it, Can I tell you? It might have been my fault, but I will double check. Okay?
Thank you.
All right. So we try to let you, when you leave here, leave this program. It's not just book, but more practical things on how to manage when you are there on the ground. That's what we aim to do. So we know that we have glitches at time, and sometimes we have to reschedule and we have to wheel and come again. But work with us as we work with you, because we want you to leave the program better able to do what needs to be done out there on the field. All right? So have a great rest of the day. I believe you have a session starting at 10 o'clock. I'm not so sure, but have a great rest of the day, everybody.
Take care,
Thank you,
Mrs.
Miss.
Walker.
You too.
Yeah, thank you.
Thank you so much. Hi. Yes, please. Can everybody see, or should we turn off the lights? All right, great. So good morning again. My name is Gabrielle Mitchell. I'm the Director of Research at the National Council on Drug Abuse Department, and I will be presenting on methodologies used to determine the epidemiological profile of drug abuse or drug misuse. So generally, epidemiology of drug misuse in the Caribbean is studied through three main lenses: prevalence and trends. So what are the most commonly used substances? The usual alcohol, ganja, tobacco, patterns of use, age, gender by socioeconomic status, and as well as emerging trends like new psychoactive substances. The other lens is through determinants and risk factors. So these lead on from the prevalence and the trends. So determinants and risk factors include social determinants like poverty, unemployment, lack of education, housing, access to social welfare, society, that kind of thing. Geographical, cultural, and social attitudes towards drug use. As you know, this changes even within a country, outside of countries in different regions, but even within a country, rural versus urban. And even within the urban, the different areas within an urban sections. Family and peer influences, religion would also fall here as well, and genetic and psychological predispositions. Health and social consequences. So mental health, the impact of or the relationship with depression, psychosis, substance-induced disorders, and the social and economic burdens. So crime, family disruption, workforce productivity loss, access to school, otherwise known as truancy, that kind of thing. So public health strategies for addressing drug misuse include epidemiological approaches, as well as policy and legal frameworks, and regional and international collaboration. So within the epidemiological approaches, we have primary, secondary, and tertiary prevention. So this relates to the kind of the macro, the micro, the meso, the ecological, everybody knows the ecological model? Yes. Great, right. So the school and so we have school and community-based education programs. Those can go as small as basic school, high school, university, primary school. We also have early intervention and harm reduction strategies. So early intervention would be for students who are in high school and they have taken up smoking, and we try to stop them before it becomes like a continuous habit, because cigarette smoking is really and then harm reduction strategies would include, some sex workers use MDMA to be able to carry out sex work. A harm reduction strategy in that respect could be in response to new psychoactive substances. So identifying which Molly is Molly and which Molly could have potentially dangerous adulterants. So even cocaine, for instance, can be adulterated with various things. So it's harm reduction in that respect would be how to identify which drugs are safe to take and which drugs are not safe to take. Because when you add an adulterant to Molly, recent trends have been to add fentanyl and meth. So it's kind of like looking at the pill and looking at the edges of the pill and the stamp on the pill, that kind of thing. So that would fall under harm reduction. And then tertiary prevention would be treatment and rehabilitation programs. Policy and legal framework. So, Jamaica has signed various drug treaties that would fall under that, as well as the Dangerous Drugs Act and the amendment. And then regional and international collaboration is cut off. But in that respect, so within the region, various Caribbean drug councils have meetings and conferences with each other, so we can kind of keep track of not just the trends, but kind of compare the trends along the route of the drug shipment routes. And kind of that ranges from not just drug councils, but also different police and military of different countries also share that kind of information with each other. And then Jamaica, a lot of our drug surveys have been done in collaboration with the World Health Organization or the Organization of American States. Right, so how does the NCDA fit into this? So we are, one moment, this is a dramatic slide. So we were established in 1983 to address drug demand reduction. So how we do this is by conducting research on prevalence and patterns of drug use. We also develop and implement national evidence-based prevention and treatment programs. We inform policymakers, using all of this data also, we inform policymakers and key stakeholders and the public about substances and their effects. We also conduct capacity building among partners. It's called an SBIRT, so it's screening, brief intervention, and training, I believe. And we do this in various communities, as well as with teachers among the primary, secondary, and tertiary as well, so that they can identify and then treat, or identify and refer. We also collaborate with government ministries, agencies, departments, so non-governmental organizations, faith-based organizations, that kind of thing, to support national and community interventions. And then we also partner with regional and international agencies. So as I previously mentioned, so the World Health Organization, the Pan American Health Organization, CARICOM, that kind of thing, right? Is everybody following? Great. Okay, so regional and international methodologies. So through our partnerships, we contribute to development, recording, and compilation of drug demand information. So what would happen in that instance is organizations like the Inter-American Uniform Drug Use Data System, or sometimes the World Health Organization, would send this huge form that they would send to us. They would also send it to the police. So we would put our information regarding because we do community prevention and also community treatment. So we would supply them with that information, and then the police would give them drug demand and drug supply information because they would be doing seizures and such. And then we also, the National Council on Drug Abuse also participates in the Global Tobacco Surveillance System, which is a series of surveys. We usually do the Global Youth Tobacco Survey, and it's a standardized survey. So we would do it, other countries would do it, and then we could compare that data across the countries in the Caribbean. So a few papers have been written using that data. And then we also do the Global School-Based Health Survey, which looks at adolescent health, so its risk and protective factors. These two surveys, the Global Youth Tobacco Survey and the Global School-Based Health Survey, are very long. I actually have the 2025-2026 here to share, so you guys can look through that in the meantime. And then our data sources. So we do surveys, both household and school-based. We also do prison surveys, university surveys, treatment, emergency rooms among the homeless. We also do rapid situational assessments. We have a lot of qualitative research as well, interviews and focus groups, and hospital admissions, emergency department logs, coroner's reports, medical examiner's reports, treatment center reports, and then we also have the drug-related crime statistics that we would get through our partnership with the police and the military. Oh, this is not come up with. Anyways, right. So over the last 20 years, we have done quite a few national surveys. So the Global School Health Survey, as I previously mentioned, was done in 2023, 2017, and 2010. The Global Youth Tobacco Survey, we've also done about 4 times. The National Household Drug Prevalence Survey was our most recent survey that was done in 2023. We did do a public awareness on ganja decriminalization in 2020, which was 5 years after decriminalization. We've also contributed in studies during COVID. We also looked at gender within the criminal system. We did a homeless population survey, a rapid situation assessment in 2017, but we also did one during COVID, but that was a qualitative done with school children in about 2022. We also did a Jamaica prison survey, and then before we did the Global School Health Survey and the Global Youth Tobacco Survey, we used to do the National Secondary School Survey, which was kind of an amalgamation of these two, but we have since switched over. The standard has been changed to do the first two. Right, so why conduct national school surveys on drug use? Well, doing surveys on drug use gives us quite a bit of information. So prevalence and patterns of youth drug use affect health and welfare of the population. But the national school surveys also ask questions about what's going on within the home, for instance. So has anyone ever vaped in front of you inside of your home? Has anybody smoked in front of you inside of the home? Do your parents smoke? Who was the first person to give you a drink? How old were you the first time you had your first alcoholic drink? Not just the question is worded like not just a few sips, but when was the first time you had a whole drink, that kind of thing. So we get a lot of information that way. And that's useful because it helps us to not only monitor the trends, but also to kind of identify how we would go about both prevention and treatment in those respects. Because if it's a case where the child is being exposed to alcohol within the home, then clearly it's more of a family intervention that is needed and not just an intervention with the child within the school community, if that makes sense. Is everybody following? Okay, great. Okay, so in 2023, we did the Global School-Based Health Survey, but this was within the confines of a project called the Empowering Adolescents Study. So this study was done in 4 cities. They're known as second cities. So it's done in Spanish Town in Jamaica, Fez in Morocco, Segundi Takoradi in Ghana, and Jaipur in India. So the rationale for choosing the secondary cities was because capital cities usually get a lot of the resources. So this study was focusing on kind of investing resources into second cities and using the Global School-Based Health Survey to identify risk and protective factors so that we could adequately address them within these second cities. So this was to ensure regional and cultural diversity, as well as these countries had an existing interest in adolescent health. So this study is being done in collaboration with not just the health systems within that region, but also with the World Health Organization and the Pan American Health Organization in Jamaica. The Global Youth Tobacco Survey, as I previously mentioned, is the standard for measuring tobacco use among youth, this was 13 to 15, but it's actually 12 to 17. So the questionnaire is being passed around, but it's a very long survey, and how the survey development goes for this is there are a set of core questions, and then there are a set of optional questions. And then there's also adjustments made depending on language and slang. So for instance, when we drafted this survey, we would have had to have added Grabber to it, for instance, because Grabber wouldn't be something that the people in India would be using, or outside, or like Barbados, for instance. That's not really a big issue for them there, but Grabber is an issue here. So we would have had to have added Grabber questions to kind of specifically tailor it to the Jamaican context, right? So we have done four rounds. We've actually just completed the 5th round in March, and it's school-based and self-administered. So how that works is we go to the schools. So the World Health Organization gives us the sample. They choose the schools. So we go to the schools, we administer the survey. The children shade, we kind of give them instructions. So they shade, they respond, we collect everything, and then we go. And it's basically the standard. So the World Health Organization does the sampling frame, the school selection, and they give us the core questions. But the Global Youth Tobacco Survey has you can actually look it up online and see which questions are core. And for the same with the Global School-Based Health Survey. So as previously mentioned, in 2023, we did the National Drug Prevalence Survey. This was among the entire population. So because it's done in households, it also includes adults. And sure. Right.
How does the WHO choose the schools?
So
send them all the schools and they randomly select?
They contact the Ministry of Education to get the full list, but because they've been doing it for so many years, I have a general list, but for instance, it's all public schools. So every couple of years, sometimes a private school may become a public school, as has been the case recently. So they would recontact each Ministry of Education to get the full list. And then it's a little tedious. So they have the list, they organize the list by urban and rural and by parish, and then they have to do the weighting because it has to be representative of the entire high school population within the island. So that's when they get the full list, and then they take off the private schools. Does that answer your question?
Yes. Thank you.
Great.
Do you have to go through Jamaican ethics, or do they have their own ethics?
We go through Ministry of Health and Wellness, and then we have to get permission from the Ministry of Education.
Is that challenge population?
The prison one, at the time I wasn't employed there, but from what I understand, the prison one, you go through the Ministry of Justice, because when you are in prison, you're a ward of the state. So just like with the children, you have to go through Ministry of Education. With the prison population, you go through Ministry of Justice and Peace. Is that their name? Ministry of Justice and Peace. So they are who are responsible for them. So that's who we would go through to seek permission to do that survey. When working with the prison system, you basically have to follow their rules, follow their guidance. And Ministry of Justice is super strict. So right, so you go through their process in order to get through to do that. Okay. So, right, I was talking about the household survey, the National Drug Prevalence Survey. So this was done in collaboration with the Center for Leadership and Governance at the UE, as well as the Inter-American Drug Abuse Control Commission protocol. That would be their protocol and their questionnaire that we would use. And it's a cross-sectional survey, stratified multi-stage cluster sampling. So what that means is they need a census, they need a general population, they need to know what the parish population density is for each parish. And then they would go through that way to make sure that it's a representative survey. So it would kind of tell you how many households. So you kind of go into a community, it would tell you how many households you would skip. So it'd be the first household, the third household, the fifth household, something like that. And then so this survey was to determine the prevalence of not just psychoactive, but regular substance use among Jamaicans 12 to 65 years old. And it looks at regular socio-demographics, substance use, risk perception, access, treatment, driving under the influence of both alcohol and also marijuana, and attitudes towards drug policies. So it's a representative sample based on the multi-stage sampling that was done. And in all, we had about 4,991 respondents. Now, you may ask, why do a household study and school-based studies? I don't know if anybody's asking that, but I'm going to tell you anyways. If you're doing a household study, usually the whole family is at the table. And if you are at the table with your parents, you're not really going to be as honest as you would be if you're just in your classroom and your teacher was around the back. So that's why we do both. And then this is can everybody see this? Right. This is the kind of results of the 2023 survey. So it's mostly prevalence here. So national prevalence, nobody's surprised that the alcohol drinking is high, followed by ganja and cigarette smoking. Also useful, so I'm not sure if everybody's aware, but there's a corridor here where we have we have a lot of car accidents, as well as over here in this region. And then if we look over to it would be my left, but you're right, we could see that we have had an increase in drunk driving from the 2016 to the 2023. And you can see from the little alcohol bottles that the prevalence in this corner is close to, if not higher than the national prevalence for drinking. So this is the kind of data we could get from surveys like this. As well, we can kind of identify. Hello?
Hi. Question, just asking, in future, is it possible for you to use the pointer to point on the screen, please? Because I can't necessarily see when you say pointing to like this area.
Okay, all right. I am not sure where the pointer is, but I'll try to be a little bit more descriptive. So if we look at what was I saying? Right, so we have the alerts in the bottom corner. We can identify that Trelawney, St. Anne, and Kingston have higher than the national prevalence for alcohol drinking. And then Kingston, Trelawney, and Clarendon are on alert in terms of ganja smoking, cigarettes, St. Andrew, Trelawney, and St. Anne. And then within the drug prevalence survey, there are two scales. One is to look at harmful alcohol drinking, and one is to look at harmful ganja smoking. So based on the results of that survey, we can identify that harmful alcohol use is highest within the 25 to 35 age group. And current ganja smoking is highest in the 18 to 25 age group. So this data is important in terms of if we want to do communication campaigns, who would we tailor those communication campaigns to? Who would we target to do prevalence interventions with, and in what context? So for this 18 to 25 age group, this kind of would signify that we would kind of need to look at the tertiary school systems in terms of prevention campaigns. And then because we have done this survey in 2016 and then redid it in 2023, we can compare the results. So as I previously mentioned, there was an increase in drunk driving and a decrease in drug driving. There was an increase in edible use. Daily tobacco use also went up. High risk of ganja use also went up, and harmful use of alcohol stayed the same. So what are the implications of this survey? So it identifies that there's a gender disparity. The burden of substance use is disproportionately higher among males. Problematic substance use is evident in the specific parishes, so Trelawney, Clarendon, Kingston, and St. Andrew. We have an increased proportion of high-risk cannabis users as identified by that specific scale. And then the lowest risk perception on vaping is among youth. And access to treatment services are also hampered by low awareness. So a lot of people don't know that treatment services exist in their specific parish, in their town, or even within various agencies. So that kind of leads us to the fact that we need to do more public education, both on risk perception and increasing awareness, as well as where people can access treatment. Right. It also identifies that there's a need for substance use treatment because approximately 3% felt the need to stop, but they didn't know where to go. And again, So again, it's higher for males because, right, sorry, I lost my train of thought. So this is higher for males where they want to stop, but either they don't know where to stop or they don't feel like they're ready to stop. Then the survey also had a section about reasons for not accessing treatment. So here we can see that a lot of people don't know where to get treatment. 36.6% overall said they don't know where to go for treatment. And then that's followed by people who said they're not ready to stop using, or people saying that they can't afford treatment. Right, so the next study we did was COVID and drug use. This was in collaboration with the Organization of American States, and it was an online survey. Now, with online surveys, I'm not sure if you know this, but women answer surveys online more than men. So if you're doing an online survey, you may see that phenomenon come up. That's actually happened to me twice personally. So with this survey, the gender distribution was actually 77% female and 22.5% male. We had about 798 persons participating, and because it's an online survey, it's a convenient sampling. So you're really using anybody who will answer the survey within your demographic that you're trying to look at. And the age distribution is the majority of the respondents were between the ages of 18 and 39. Which is, again, not surprising because that's the population that is most on their phones and receptive to questions. Right. So this survey indicated that there was actually an increase in psychoactive substance use during lockdown among participants who had used in the past year that the survey had been conducted. So ganja and alcohol are about the same in terms of percentage use, and then it's followed by tobacco and a small percentage of crack cocaine. The reasons for increased use that were reported were, again, it's COVID, so social isolation was a big one, as well as stress and anxiety and loneliness. Boredom was also high on that scale, and money problems and work problems, because again, it's COVID, people are either working from home or if they've lost their jobs. So there's more time to stress, more time to be anxious, more time to worry. And it's in those scenarios when people tend to increase drug use or start using drugs. So the value of qualitative research, this is I'm really hoping that everybody knows the value of qualitative research. Qualitative research is very useful in terms of context. It's the basis for the design of interventions, especially among youth, because you get a better response from children if you have them in a room and they feel like their voices are being heard. Children love to talk. It's just, do they feel safe enough to talk? So for instance, as I previously mentioned, if we're doing a household survey, they're not going to be completely honest if their parents at the table. But if you have them in a room, and even if the teacher is at the back, you will still get a lot of information from them just from that conversation. And human interest stories, and you would otherwise lose a lot of these stories if you're just looking quantitatively. So for this global health-based survey, for instance, the way the questions are worded sometimes, they don't, when you get the question, the actual answer sheets, they have scribbled answers under the question on the bubble sheet. So there's a lot of information that they have. So it's like, yes, I only get alcohol when my friends give it to me, but there is a lot of information that we miss out on when we're doing solely quantitative research. And then we also did a separate survey. This was a qualitative survey with the youth in 2021. So this was during COVID. So this was a list of difficulties that the students said they faced because of internet issues, maybe at home, or a lack of devices. There was a lack of connectivity. They felt socially isolated. They had a significant amount of mental health issues, anxiety and depression. Home dynamics were also hard for some of them. There's a lot of abuse, discord, and distractions. And for a lot of these students, school is a safe haven for them. So COVID was especially hard. They didn't see their friends. There was no serious socializing. They basically locked up in the house. They didn't feel like they had any opportunities to express their feelings. They don't really talk to their parents like that. And then some communities, they kind of go out into the community and feel vulnerable. A lot of them perceived an increase in substance use among their friends, family members, community members. They felt like they had a difficulty adjusting to online learning, especially math. Like math was a little difficult for them to learn via the computer screen and the camera. It wasn't as helpful. The teacher is not there in the room with them to kind of coach them through. And there's a lot of hopelessness related to that and a fear of academic failure, because if you're in a classroom and the teacher cannot see you actively struggling, you're not going to get help behind the camera as well. So we also asked them about their perspectives returning to school. Some of them were afraid of returning because they weren't sure if they could keep up with their peers. If they went back to school, they may have fallen behind via the online learning. There's also the doubt about adherence to COVID protocols. So this was around the time we were telling the students that they would have to wear a mask to school and the hand washing. So there's a lot of anxiety there. Then some of them had adjusted to virtual learning. Either they were okay not being in a class and just doing the schoolwork, or a lot of them just had the camera running or the camera off and gone to the other things. So there was that. A lot of them were looking forward to socializing with their peers. Some of them misengaging with their teachers. Some of them were more equipped to handle the digital world than others. Some of them wanted to escape the distractions of home. As I previously mentioned, school is their safe haven. There's increased accountability at school, increased responsibility with virtual learning. And then some of them mentioned there's a lack of understanding and empathy at home. So if you are struggling to learn at school and your parents don't really know how this computer thing work, they're just in a WhatsApp group and the teacher called them name and say, your child is not doing so and so without that can cause conflict as well, as has been mentioned. Right, so this study helped us identify the priority needs for the students. So clearly there was a need for mental health support. So counseling, encouragement, opportunities for self-expression. The students needed social contact. They needed opportunities to engage with their peers in smaller settings that could have been more socially distanced. And in terms of academics, very obviously a lot of remedial support would be needed to address those lost educating hours. And there was also suggested that a focus on the essentials would be needed in terms of not overwhelming the children with things in that respect. So we also did another rapid assessment in 2022 about the main issues affecting adolescents. So as you know, adolescence is a serious time, it's a lot of stress, it's a lot of mental and physical stress. And so mental health, anxiety, depression came up, as well as suicidal ideation. And we see that coming up a lot with our youth. So even with the previously mentioned St. Catherine's study, suicidal ideation was high within a lot of those students. And that study would have been done in 2023. So that could have also been COVID related as well. A lot of students were worried about aggression in schools, fights, weapon carrying. So I have heard reports that sometimes it's not like children these days are not resorting to like stabbing people with a pencil, like people are bringing weapons to school. So that was a cause for concern. There's also excessive sexualized behavior, pregnancy, the hyperactivity. So quite a few students may have ADHD or ADD, but they have not been diagnosed and the teachers are not trained to deal with that. So a lot of students get left behind in that respect. Drug use and increased access, but also exposure. And then the increase in scamming. So a lot of students, especially in the western end of Jamaica, kind of like, I don't need to learn this. I'm literally leaving school to scam. Like there's no money. Right. And you ever see some of the money these scammers are making, you're not paying attention in school. That's a waste of time. So this study also brought up involvement in occult practices. So that was also a cause for concern. Inappropriate social media use and exposure. There's a lot of that going on. Lack of parental guidance and participation. Influence of popular culture, as well as coping with a chaotic home environment. So this qualitative rapid assessment in respect to the inappropriate social media use and lack of parental guidance, there is a question in the global school-based health survey that asks questions about if your parents have rules for how much time you can stay on the phone and how much time you spend after school, like lying down and on your computer and that kind of thing. So that kind of works in a way to say, well, clearly some students have no parental guidance using on social media, and the qualitative data has also reinforced that as well. So that's a way the quantitative and the qualitative kind of come together in that respect, because if we're getting the same data on both of them, then definitely something is going on. Right. So in following, so I'd also mention the increased access to drugs. So this qualitative survey pointed out that students they're doing drugs. So Molly, vaping, and edibles seem to be the big ones. So the Molly came up in a lot of, so students know about Molly because of dancehall culture. So even when we're doing the survey, for instance, a student would raise their hand and say, Miss, I don't know what this word is. I don't know what ecstasy or MDMA is. And you can go to them and say, you know, Molly that Skank sing about? Oh, yes, miss. And then can continue to answer the question in peace. And that is how students are learning things. They're also learning things in the communities, the older siblings, they see a man vaping, they can buy a vape at a gas station, at a wholesale. Sometimes students are bringing vapes to school to sell. And then the edibles is another big one, because the edibles is not, we haven't seen the edibles as just brownies and cake. You can now get Buster. You can, I'm so sorry. You look really fat. I'm so sorry to kill that bubble for you. But we have basically culturalized edibles. So however you want the edible, you can get it. And the students have access. And
labeled properly?
When you say labeled properly?
I would accidentally buy a Buster that was infused.
I'm not sure if you would accidentally. So the instances I know of, if you are buying a Ganja Buster, you know it's a Ganja Buster because you want a Ganja Buster. In terms of labeling, we have looked at some of these labels. There's no information about potency. And sometimes the information about how much to take is very vague. So we have had instances where the students themselves are reporting that sometimes they take too much and things happen. And sometimes the teachers report the same thing because sometimes they do drugs at school. So
how do you know if it's like mixing something else?
They don't know. That's a part of the problem. They don't know. Yeah, so this is what the students themselves are reporting. And as we continue, sorry?
I just had a small question. How are the kids with respect to shrooms?
We have not had many reports about that as yet, so I can't speak to that personally. I think so far, shrooms has stayed in the adult population. The issue we're having with the children is a lot of polydrug use. So they are mixing the alcohol. So lean was a big thing a few years ago for them. So the cough syrup, the alcohol, the sweetie, and the vaping, anything. Those things are relatively easy, and I think shrooms are a little bit harder to mix in terms of the effects of them. But we haven't seen, shrooms is not something we're seeing as yet. And I would hope to keep it that way personally. But we're seeing a lot of polydrug use with the usual suspects. So the alcohol, the tobacco, and the ganja, just in various forms. So the students also like, the edibles is not just ganja edibles. They also like you can get jello shots. Some supermarkets and gas stations sell alcohol jelly shots. So the students are also using those as well.
Also have a candy that comes with that jelly ball.
Right. And some of the vapes, I saw a teacher showed me a vape a few weeks ago, and it looked like, you guys remember the push up, right? Somebody showed me a vape. The teacher told me she confiscated it. It looked just like that. So that is happening, right? And then in continuation, somebody mentioned, how do they know? I'm about to tell you, it gets worse. So an emerging global but also regional concern is new psychoactive substances. So these are substances that are made in like a lab. So natural drugs are like ganja, cocaine, and the shrooms. New psychoactive substances are completely made in a lab. So in 2024, there were 1,245 individual. Sorry?
Oh, I was thinking like acid, MDMA.
MDMA is partially, because it starts as a mold. I think so. It's partially, they add chemicals to it after, but it's half and half. Right. So a UNODC early warning advisory on new psychoactive substances suggested that this is an increasing concern. It's significant because there are a lot of cases involving multiple NPS. So this is what I mean is, how do I explain this? It's never just one NPS in the mix. So I don't know if you guys remember, when was that? I don't know, last year, the year before, when P. Diddy, they raided P. Diddy's house, and they found the baby oil and the pink cocaine, otherwise known as 2CB. I don't know if you guys saw that report. He had a lot of pink cocaine. Pink cocaine, a lot of the time, is not cocaine. There's no cocaine in it whatsoever. It's meth, fentanyl, sometimes a tubes of crack, like it's a mix-up situation happening. So a lot of the time you would take one of these pills thinking it's one thing, it's something completely else, and because there are a bunch of substances mixed together, you end up with polysubstance use and you didn't even plan for it. So this is posing a challenge as well because they're easily synthesized. So, okay. I did in collaboration with our international partners, I did a illicit substances course in February, and it was held by the DEA, the Drug Enforcement Authority. And they were basically telling us the recipes to make some of these NPS. You could go to Ligonier Lane Pharmacy and pick up the items to make these NPS. You just need to have some form of cooking skill and chemistry to kind of figure it out. Like these NPS can be made you can make them, it's about 36 hours of work straight. And the financial input is small, but the financial output is ridiculous. Like you could spend like $100 on something and end up with. So that's posing a significant challenge because with the advent of access to the dark web, the black markets, and then the various drug transshipment ports, it's difficult to enforce, to catch, to seize, because on top of it, the way the DEA made it sound, there are a lot of, I'm trying to tell you the chemistry of it. So it has a base and it have a addition. The DEA, the United States could ban the addition. China could also ban the addition. and the cooks can either split up the addition, so they break down the addition into ingredients and access the ingredients, and then they can ban the ingredients, and then the cooks can find a different set of ingredients to make a different add-on that would do the same thing. So the United States and China, because a lot of these chemicals come out of China, and in China, it's easier for them to ban things, because in China, everybody, them just said it, ban, and that can help. But because of the chemistry is apparently infinite. So once you have a base, you could even break down the base into 2 ingredients or 4 ingredients and buy and transport those ingredients separately, and then get your cook to do whatever you need to do to make that base, do whatever you need to do to make the other base, and then put everything together. So all they've done is added extra cooking time. But because of the extra cooking time, they can then inflate the price of these drugs exponentially. So that's one of the main challenges to regulation. And then common adulterants, anything can be an adulterant. Paracetamol, cataflam, caffeine, the baking soda, and then a lot of these on the slide are things I can barely pronounce. So benzocaine, sometimes sugar, phenacetin, levamisole, sometimes they will add a little Xanax. So that obviously causes significant health risks because you are taking something thinking it's one thing, it's something completely different. And when the only way they can find out exactly what was taken is in like a post-mortem, when they will do like an analysis of the blood and they would find so cocaine breaks down to show something else. It would be that something else that would show up on the top screen, basically. And as well, the health risks are actually crazy because if you are taking, so for instance, when you take MDMA and you have an increased heart issue, if you have a heart issue that you don't know or you have high blood pressure and then you're taking this mix up, you don't know what to do, what to happen. And sometimes even with just fentanyl, so fentanyl has a whole bunch of dupes, so to speak. The people in these labs, they do a whole bunch of dupes of fentanyl, and the dupes of fentanyl are sometimes more dangerous than the fentanyl itself because fentanyl is deadly in a 0.2 milligram. Correct me if I'm wrong. It's like you don't, like a high dose of fentanyl is lethal. So if you are somebody who is used to taking a prescription painkiller, so you're taking regular opioids because fentanyl is way stronger than heroin. So if you are a heroin user on the streets and somebody sells you heroin, you are going to take your regular dose of heroin thinking, yeah, man, it's just heroin, it'll be fine. No, you are taking your heroin dose in fentanyl. You're immediately frothing at the mouth. And your heart will stop, your fingernails will turn blue, your lips will turn blue. And if somebody doesn't get the Narcan to you immediately, it's over. So those are the significant health risks. I think I took a detour there. Right, so locally, synthetic drug use is increasing in popularity. These pictures are from a few years ago. The synthetic drug use also includes synthetic marijuana. So they process the marijuana into a liquid. Sometimes they add extra stuff to that as well, and they will pour it over mullein leaf. It's a type of tea. So they'll pour it over mullein leaf and like soak it in, or they'll use various other like herbs to simulate ganja, and that also poses health risks because they've added the places that they make these drugs. I have seen the pictures; they are not sanitary. They are not sanitary. They showed us a picture of, it was a video of, I should have added the video to this slide now that I'm thinking about it, but it's a video. They're in this building and there's like a tarpaulin on the floor. And this guy is like half naked. He don't have no mask, he don't have no gloves. And he's spraying the synthetic ganja on the plants and he's just walking around the tarp. So foot and touch. Right, so there's that. Locally, we have seen an increase in drug seizures, and there has been evidence of fentanyl. And there is a need for a rapid response mechanism because, as I previously said, overdoses are easier to take on the synthetic substances as well as on the fentanyl. And then some of these flyers were from pill parties that were happening, and the pill parties were among high school students, I believe. And yeah. Right, so how do we fight this? How do we try and combat this issue? So what exists now, there is a national early warning system for the region. This actually originated in Europe. So Italy's early warning system is about 20-something years old. We recently started. This diagram is a little old because Guyana's EWS system is actually operational. So a few of these countries are now fully operational in the light blue. And how the early warning system works. So it's a consortium, right? So it's a consortium of different relevant agencies. So NCDA, Customs, because they would be dealing with seizures at the border, the police, Ministry of Security, Cabinet, RISE, because they would do treatment, Ministry of Education, because they would also be, they would need to know because of the children in schools, various regional health authorities, the fire brigade, obviously Ministry of Health and Wellness, and this, we do also have Ministry of Justice and Peace. We're missing some logos here, but basically the idea is the early warning system is a group of all of these people who would kind of have an MOU on sharing information. So Customs, how the chain of command goes is if Customs catch something at the border, whether sea or air, they would need to submit it to the police. The police would submit whatever they picked up to the lab. The lab would test it, identify what exactly is it, and then they would come back and create an alert. Now, we are still in the stages of developing our alert systems, but what an alert would entail, because other Caribbean countries have posted alerts. So what an alert would contain is the chemical name, the street name, appearance, so if it's a powder, a pill, a crystal, and pictures, various forms of potency, warnings, health effects, and any possible adulterants as well. And then how this works is, so for instance, in January, Guyana and St. Lucia both sent out alerts of seizures of THC and ecstasy. Those seizures were both in December over the Christmas period. So how you can kind of look at that information is, if you're looking at the drug transshipment routes, you can kind of see that it could start in Guyana and go up. Argentina does a lot of alerts, but their alerts are mostly about synthetic substances. Whereas the Caribbean, our main issues right now seem to be the usual issues with the addition of the ecstasy, Molly, MDMA. Sometimes the MDMA has been seized at the border, and when it reached the lab is saying it's just meth. So there is that as well. So this consortium actually helps in evidence sharing so that we can all kind of get an idea of what is going on and what to look out for. Barbados and Bahamas, for instance, well, let me start with Bahamas. Bahamas, for instance, because of proximity to the States, they have had quite a few fentanyl cases, but their fentanyl cases are, when you look at the breakdown of the lab reports in the toxicology report, the person probably tried to buy a Molly or cocaine and fentanyl was in it. So that is helpful. That kind of information sharing is helpful because then we can kind of say, okay, well, if we are doing harm reduction for sex workers, for instance, they think they're buying Molly to do work. And we now need to say, hey, be careful of these color pills, or if the pill look a little misshapen, or if the pill have this design on it, because this may not be Molly, this could kill you. So that's how that's an example of how that information sharing is very useful.
Hi, good morning.
Morning.
I have a question. So there's this rise in sentiment in the US about narco terrorism, and there's this
Right.
counter cartel coalition that's been aggregated now. Does this emergency system share any of their information with the counter cartel coalition?
I'm not sure about the cartel coalition specifically, but because of the EWS, so the EWS exists. So for instance, the National Council on Drug Abuse is a part of the EWS. We have our information we share with members of our EWS, as well as when we go to conferences with other members of other Caribbean countries to have that discussion. So for instance, the DEA would know about the early warning system because the alerts are on our website. But I'm not specifically sure about the coalition.
Thank you so much for answering my question. I'm just
Great.
checking if they're actually doing what they say they're doing, and if they're actually liaising with the organizations that would make sense to liaise with.
In terms of the coalition?
Yeah, in terms of actually targeting drug cartels as opposed to innocent civilians.
Oh, I personally can't speak to that. I'm not sure. That sounds like it's above my zone of knowledge. But within the Caribbean and the region, so including Latin America, our Organization of American States. So the US is included in the early warning. They also have an early warning system. So whatever information that would be shared within the system, they would have, but I can't speak specifically for the coalition. Does that help? Or that probably wasn't helpful.
I mean,
I can't speak to that.
Okay.
Okay. All right. Okay, so priority data for the EWS. So as I previously mentioned, reports on seizures of psychoactive substances. So the police and the JDF and the Coast Guard would provide that kind of information. Where were the drugs coming from? Where were the drugs supposed to be going? So I don't know if you saw recently that they did there was a seizure of cocaine, and they could tell us the 3 Colombians who were involved with the seizure, and that the seizure was supposed to go somewhere else. So that's the kind of information we need. Who is doing it? Where them come from? Where the package come from? That kind of thing. And then the chemical characterization of the substances. So this is where forensics and the pharmacologists would come in. They would look at the substance and tell us what it is. And then identifying the patterns of use. So if we know where the drugs were seized, who they were in the hands of, and where they were planning to distribute to, because the police would get that, they would run that investigation, then we can actually analyze the patterns of use. So if a lot of the NPS that come into the country are to come in and go out, then we can say, okay, this is a part of the drug transshipment route and not for internal, locally island use. It's just to come in and come out kind of thing. Whereas if we're seeing the pills come in, but when the police run the investigation, the person might confess and say, oh, this is not the first time I brought in pills, or the person who bring in the pills, sometimes they steal some of the pills to sell locally and the pills show up on the North Coast somewhere. That happens. Sometimes on the Northern Coast, with tourism comes cruise ships. Sometimes people bring in drugs on the cruise ship with them to take personally and share with people. And sometimes when they share with people, it ends up in other people's hands, that kind of thing. So this is helpful for us to identify the patterns of use and also the patterns of administration. And we also are able to identify new drug consumption patterns. So is it a case of, are people only doing these substances during peak seasons like Carnival, Independence, Christmas, or is it a year-round thing? So basically context is key in these instances. So this is the kind of data we need. We also need to know reports of clinical cases of intoxication or overdose. This we would really get from the health sector. So emergency rooms, sometimes GPs as well. And then the forensic analyst results of death due to drugs. So if people overdose before we can do something and they run a toxicological screen, a tox screen, we can see the breakdown. We can see what the chemicals broke down to be. Because you're not going to actually see cocaine. You're going to see the breakdown product of cocaine. The name of it is escaping me right now. And then also age, gender, what time they came in, where did they come from, did the ambulance pick them up at home, were they at a party, what happened? Right, so the toxicological information on the autopsies, and then report on the harmful effects. So if we can get an idea, so if the person took some pills and they still have the pills on them, for instance, we can run tests on the pill to see what the milligram, what the actual split is within the pill. And that is helpful for us to kind of identify harm. So is it risk of seizure, heart attack, death? Well, but also increased temperature, pupil dilation, dehydration, that kind of thing, especially when the intensity as well as the combination. Whew. All right, we're getting to the end. I'm so sorry, we've been talking for a very long time. So we are conducting research. You guys are probably thinking, how do you guys fall into this? So research is very obviously a collaborative effort, always, if you want to get the real context. So we always, when doing research, we always need to think, where are the gaps? What is the information that we're missing? Is there a population that we're missing? That kind of thing. So we try to align with the experts and the leading researchers in the field. So join a team, national, regional, global. I mean, there are Jamaicans everywhere. There is always a SWAT. Broaden your scope of knowledge, because Jamaica and the Caribbean don't exist in a silo. We are a part of a drug shipment route, but also popular culture, music. There are lots of things that influence drug use context or drug trafficking context. And facilitate research evidence. So facilitate research implementation. So evidence is always essential. How the National Council on Drug Abuse runs is everything is based on evidence. So evidence-based prevention, evidence-based treatment, because you can't be preventing something that isn't happening, or that you have no idea how it's happening, where it's happening. So that's important. And you guys are probably asking, so what? What was the point of all of this information? So really, to sum up, we need to see population trends. This is the evidence base. Population trends influence prevention priorities and treatment needs. It also tells us who needs to be treated among the adolescents and the adults, because adolescence is a very long time period. Adulthood is a very long time period. I mean, if you're looking at COVID, for instance, a lot of people were locked up. How were the elderly doing in that time? Were they drinking more? Were they smoking more cigarettes? Which parishes, urban, rural, those things are always important. Schools and communities, yes, because people don't exist by themselves. And then all of this helps us to either influence policy, help to develop policy, help us to change policy. So even in the instance of the new psychoactive substances, those are not included in our Dangerous Drugs Act. We therefore need to collate more information about them so that they can be included. So all of this is based on research. And any questions?
So similarly to how we have disease surveillance, the NCDA, I'm assuming you guys have a platform where you can monitor the trend over time, but are you able to see, I'm trying to compare it to for example, with dengue. So we would be able to say, okay, well, we're having, this is the baseline amount of cases that we expect. So we're seeing increase in, for example, October. So wondering if it reaches alert threshold, or epidemic threshold. Do the NCD have a similar data to say, okay, well, it's carnival time or it's Christmas, we're seeing more reports of.
Right. So our system is still in development, but we have an anecdotal system. So the way the National Council on Drug Abuse works is we have regions. So we have Northeast, which is St. Ann to Portland. We have Southeast, which is St. Thomas to St. Catherine, and then Southern, which is Clarendon to St. Elizabeth. And right. So we have those health regions, and then in those regions, each parish has a parish counselor, and then the parish counselor has a team of people, and they have their relationships with the schools, the churches, the bars, the sex workers. So on the ground, we will get reports from them, and then we can act in that way. But like an actual computer system is still in development. So our early warning system that way is in development, but we still have our information sharing within the EWS. So and even within the organization, so we can act a little bit more urgent, not urgently, more. Right.
Second follow-up to that. So in that case, I'm wondering about the capacity of the public hospitals in terms of the toxicology screen. I remember when I was at UWI, I think you can pay, if we're suspecting, we can pay, the patient can pay and get a tox screen done, but I'm not so sure about like KPH, Spanish Town and so forth. Like, how do we even start testing to like know that okay, this is a application?
Well, in that instance, so if you die, they run that screen. If you survive, they have to ask you permission to take a blood test, I believe. I think that's how it works. They can't just take a blood test to test you without your permission. So if you come in that case, you can just tell them that you would like to know that you don't know what happened and ask them to do that. But sometimes also it should be noted with the NPS, sometimes they break down fast. So even some of the date rate drugs, those metabolize in and out. There's nothing to pick up at the end. So it also depends on what the drug is and how fast it metabolizes. Sure.
All right, as it relates to teams, team.
Mm-hmm.
In my area of work, there are times when have to deal with a team, right? And most of the time, for the past 50 years, I can quite a few who have been in terms of abuse and drug. Some even last week, there was a 16-year-old, and as I said, there are times when you get them in your area, they will open up to you.
Mm-hmm.
And it was quite, should I say, but I have to make reference to the social worker because this team abused, pregnant, drug, and all of that. And she spilled out everything.
Mm-hmm.
And I made reference to the social worker to follow. Now in cases like those, is there do the counsel on drug abuse, right?
Mm-hmm.
Do the social workers liaise with the counsel?
Right, they do.
Oh,
they can. Yeah.
Because I'm wondering, because I think some of the time some of these probably I don't know if they get lost in the system.
Because there are also routes of referral, but in that case, that sounds like because it's a 16-year-old that involves a lot of other people because they would have to make a police report,
yes,
CPS. So there would be a lot of stages before we would get to us.
Does NCDA have their own team of social workers or rely on the social workers in the healthcare system to?
So we have social workers employed, and Dr. Robinson is going to give a presentation on treatment. Is it treatment? Not specifically. Yeah, we have case management officers. And we have people with some of our psychosocial officers they have social work degrees.
Okay.
Any questions? Any more questions?
Slides be shared with us?
I can, I think.
Classified.
Okay. All right. No more questions for real. Actually, I really should have incorporated those slides. I'm sad I didn't. They were so good.
She shared a lot of information.
Yeah,
with you guys.
through a lot of info, all of you.
Things that I've never heard of. either,
Sorry, repeat. In Jamaica, fentanyl usage in Jamaica is sorry. So in Jamaica, it's not a drug that we have knowledge of people abusing right now. Fentanyl is mainly used for persons in extreme pain, so cancer patients. Sometimes we don't have as much access to fentanyl in Jamaica. Fentanyl is like you have to apply for a hospital to have it or a pharmacy to have it. They have to specially apply to the pharmacy council as well as customs, I think, so that they can get permission to buy it, but also to import it. So we're not.
Bring it in for the country, if a hospital needs it.
No, fentanyl is under a special class, so that's what we have to apply for, as well as the Narcan. So Narcan is available, but you have to apply for it.
Is that wise though?
Oh, you know, I don't know. So sorry to tell you.
Hello?
So, 1 second. Email for internship. Call the head office. And I could not tell you.
We can give you that information at the end. Don't worry.
Let me
Just make
WhatsApp
sure
somebody
you
and
put
ask.
WhatsApp information.
That's my best option. Let me WhatsApp somebody once I come down and ask. Somebody else on the Zoom had a question?
Yes. Sorry. Hi. I was wondering if it made sense to actually have the Narcan also as one of those things that has to be specially requested.
It has to be specially requested because of the chemical composition of it. I think there is a risk of abuse, but don't quote me.
Okay.
All right.
Okay.
All right, everyone, thank you. Please give a hand to Ms. Mitchell. Fantastic presentation.
Those questionnaires are still floating around. Who has them?
Yes, you can pass them to the front here, please.
Thank you. All right.
All right, everyone. So for our next lecture, we have Dr. Kristen Robertson Barrett, who's also from the National Council of Drug Abuse. She's currently the Director of Treatment Services at that particular department in the Ministry of Health and Wellness. So for person, Dr. Robertson Barrett is actually a consultant psychiatrist as well. She's been practicing for a number of years. In fact, prior to going to the NCDA 1 year ago, where she was highly recruited, she used to work in the government system in St. Catherine, at Spanish Town Hospital, as well as at University Hospital prior to moving on to there. So she has a lot of experience as a consultant psychiatrist, and today she'll be doing a presentation on substance use disorders, sort of an overview in Jamaica, adding on to what Ms. Mitchell has shared with us. So please, thank you. Welcome her. Yes. Sebastian. Yes, Sebastian.
Please. I feel like Christine has anything knows. Probably a lot of faces in here are familiar, to be honest.
Kristen, you have your flash, right?
No, but I can put it on. I can put it on. I can do it though.
Yes, I'm very thinking.
Rachel.
Okay, thanks. So you just put it in presentation mode then. Let me go in. So you need any technical when you start.
Usual PowerPoint.
All right, go ahead. You ready? Good. All right.
All right, guys, we're ready to start the next one.
All right. Morning, everyone. So the introduction has already been made. I'm Dr. Robinson. I'm also with the National Council on Drug Abuse. I'm the Director for Treatment Services. I'm not speaking specifically about the National Council on Drug Abuse this morning. I'm speaking specifically to substance use disorders in the Jamaican context. So just in terms of setting the framework of what is a substance use disorder. So this would be a mental health condition, right? And it's characterized by a problematic pattern of substance use, and there would be adverse physical and behavioral consequences, and it would persist despite these negative consequences. So the person continues to use despite these consequences. Substance misuse is the use of any substance in a manner, situation, or amount, or frequency that causes harm to the person or those around them. And then if we have prolonged, repeated misuse, then we can end up with a substance use disorder. So just looking at some global statistics in the global context. So the most common substance use disorder worldwide is alcohol, followed by nicotine, and then illicit drugs. But if you remember the drug prevalence survey that we saw a while ago for Jamaica, it's alcohol, then cannabis, then nicotine. So you see that we're unique in that way for cannabis use. So it's actually alcohol, nicotine, and then other drugs worldwide. There are 400 million people living with an alcohol use disorder. 1.2 billion people worldwide use tobacco. 1 in 5 adults worldwide are addicted to nicotine. And there are over 100 million people vaping. In terms of the illicit drugs now, so this is not including alcohol and nicotine. There are 360 million drug users worldwide, but 64 million have drug use disorders. The most commonly used drugs, starting from number 1, is cannabis, then opioids, followed by amphetamines, cocaine, ecstasy. In terms of treatment, in terms of females, 1 in 18 users is receiving treatment. So as Ms. Mitchell highlighted, the gap in treatment services and females are disproportionately underserved, right? Males, 1 in 7 users are receiving treatment. And so access to treatment for substance use disorders is a gap. In terms of the impact of substance use disorders, so we know that there's a complex relationship between substance use and drug-related harm and socioeconomic status. And so those of lower socioeconomic status are the ones who are more affected. I think we generally know that. There's a significant impact of mental health and co-occurring mental disorders, and that's what we call dual diagnosis. So for the most part, it's about 50%, but in some populations, it's up to 75%. You will find people who have a substance use disorder have another mental illness. There is a significant impact on the development and outcome of major non-communicable diseases. So we're talking hypertension, diabetes. So that's important as it relates to public health outcome. And then there's an increased risk of acquiring viral infections. So injectable drug users, not large in our population, truthfully, but worldwide, that's what you would see. And risky practices. So doing things with impaired judgment, unsafe sexual practices. They contribute majorly to injuries. So we're talking about traffic violence related, and it's a leading cause for global burden of disease in youth. And then of course, there's economic and healthcare burden as well. So looking at what strategies we use generally or broadly for the management of substance use disorders, the Substance Abuse and Mental Health Services Administration advocates for prevention, number 1. Then there's treatment and recovery or maintenance. So for prevention, you're going to use evidence-based prevention programs. So that's coming out of places like the NCDA and policies, which come from legislative framework. So we're going to use those and make sure they're available in communities so that the prevention is better than cure, in essence, right? And developing strong social connections to promote emotional well-being and resilience. So we're looking at how social and environmental factors can affect the decisions that youth make from an early age. In terms of treatment, substance use disorders can be treated effectively. And the primary means for that is behavioral therapy, but there are medications needed for certain things, right? So in terms of alcohol, opioids, and the comorbid psychiatric disorders, right? We use medication. And then recovery, we want to maintain remission through social networks and programs. So those questions about the social work and the case management, that's where recovery is maintained. All right, so we can look at certain categories of substance use. So we have hazardous substance use. So that's a pattern of substance use that increases the risk of harmful physical or mental health consequences to an extent that warrants attention, but not necessarily any harm happening yet. Then we have an episode of harmful use. So that's when an episode of psychoactive substance use has caused significant harm to the person, their physical or mental, or harm to another. And then there's a harmful pattern of psychoactive use. So that is when there's a sustained pattern of that harmful use that speaks for itself. And substance dependence then comes along when there's evidence of impaired regulation of their use. So that means they have impaired control over their use. There's more impact in terms of the various aspects of their life and various physiological changes that happen because of the substance. So substance misuse, in a nutshell, is harmful or hazardous use of these substances. Then we know the term addiction. So the American Society of Addiction Medicine defines addiction as a primary chronic disease. So we're highlighting the fact that addiction is a brain disease. Long ago, it would have been thought that addiction is a lack of will, or these people just aren't strong enough because, you know, but it is known that addiction is, we know now that it is a medical condition. It is a disease of the brain affecting reward, motivation, memory, and there's dysfunction in particular circuits. And so we get certain biological, psychological, social manifestations, and the individual pathologically pursues this drug despite all of these things happening to them. So it is characterized by cravings for the drug, compulsion to use the drug, and ignoring the consequences of the drug. So generally speaking, this is not gospel or anything, but you can think about it that misuse is an action, addiction is a state, and substance use disorder is a diagnosis. The state of addiction does fall underneath the substance use disorder diagnosis. So once you have addiction, then yes, you have a substance use disorder. And usually they say when you reach to severe substance use disorder, you reach addiction. So I'm gonna go through substance use disorder criteria based on the psychiatric guidelines. So we use the Diagnostic and Statistical Manual of Mental Disorders. Originally, we used to distinguish between abuse and dependence, but now it is just a single spectrum diagnosis. So we don't say you have substance abuse, we don't say you have substance dependence. I mean, we'll still use those terminologies, but based on the literature, it is just a single diagnosis and you're either mild, moderate, or severe. So this is a list of the substance use disorders that are recognized primarily. So we know alcohol, caffeine use disorder is up there. Most people are usually shocked to see that because that probably 50% of the room probably have that. Cannabis, hallucinogens. So you see the list there. Whatever doesn't fall here, you would have other substance use disorder to classify these things that we're not, that don't fall into this list. Sugar? Sugar is not a substance use disorder. You can have an addictive tendency to sugar, but it doesn't fall under a substance use disorder because generally speaking, sugar doesn't lead to the negative consequences and impairment of functioning per se. But certainly you can have addictive behavior. Yeah, you can have addiction to sugar. We know that. You throw one at me there. It's not a substance use disorder, but yes, there can be addiction to sugar, and you can have food addiction as well. All right. So a substance use disorder is a problematic pattern of substance use where there is clinically significant impairment. That is the clincher in almost all mental, not all, in all mental health conditions, you're going to find that you have to have clinically significant impairment for it to become a disorder. And it's manifested by 2 or more of the following in a 12-month period or more. So this individual might have issues with impulse control. So that means taking it in larger amounts or for longer periods than they meant to, having unsuccessful attempts to cut down, spending a lot of their time to obtain or recover from the substance, and having cravings for the substance. So that's the first 4. Then there's social impairment issues. So they will have recurrent use resulting in failure to meet their obligations. They will have continued use despite having social issues from it, relationship issues, and important social or recreational activities are given up or missed because of the substance use. Then there is risky use. So there's recurrent substance use in situations that are physically harmful. So driving and drinking. Substance use is continued despite knowing that they have a physical issue. So somebody literally has COPD, they have cirrhosis of the liver, but this addiction drives that they continue. The brain cannot stop itself. Then there is tolerance, which is a need for increased amounts of the substance or diminished effect by using the same amount. And then there's withdrawal, where there's a characteristic withdrawal syndrome, which is very depending on the substance. And the substance is taken to relieve or avoid withdrawal symptoms. So you have these withdrawal symptoms, you have to drink alcohol for it to go away, or you take something like alcohol, Xanax, to cover the same feeling. So we specify if they're in early remission or sustained remission. So in early remission means that they haven't met the criteria for 3 months, but not as long as 12 months. And sustained remission, they have not met the criteria for 12 months or longer. And this is with exception of craving. So they may have missed out all of the other ones and they still have craving, which is understandable, but they don't have the other criteria. And then we specify if they're in a controlled environment. So that would mean if they're in a facility. And we code whether it's mild, moderate, or severe based on the number of symptoms from that list. So you only need 2 to have a substance use disorder. So by that, how many people have a caffeine use disorder? Probably most. Opioid use disorder has different specifiers. They also have on maintenance therapy because they may be on a long-acting opioid to circumvent their withdrawal symptoms. So looking at some of the risk factors for substance use disorder. So of course, biological has to be first. We know that genetics and family history play a part. Substance use disorders there's about 50% heritability, with stimulants such as cocaine being the most heritable. Alcohol is also up there, opioids and nicotine as well. The presence of psychiatric disorders is also a risk factor. So we know that having depression, having PTSD, having anxiety may lead you to use a substance. But it's a complex relationship, right? Which I'll mention. That is which one came first in scenario. Behavioral and impulse control issues in childhood. So having an issue with impulse control would make you more likely to engage in risky behaviors. Having a chronic medical disease, especially a painful condition, if you are constantly in pain, you are more likely to try and abuse an opioid, to try and use cannabis to self-medicate. The properties of the drug, so some are far more addictive than others. Case in point, fentanyl, right? Addiction to fentanyl develops within days. And then early age of first use would put you at higher risk. Some other risk factors, psychological, we can look at traumatic experiences, so adverse childhood experiences put you at greater risk for just about everything as it relates to mental health and substance use included. Poor coping skills, so somebody who does not have a good support network, who does not have proper ways of dealing with stress and so on, may lean on substances. Lack of parental involvement is also found to be a risk factor, parenting style. These are risk factors for substance use disorders. Some social and environmental factors, so cultural norms and expectations. We know what happens with cannabis in this country. It is just a rite of passage. It's just something that you do. You reach a certain age and you get a spliff. I mean, I have had somebody tell me a story about his uncles giving him a spliff. He was young, can't remember the age, and he had some paranoid, anxious reaction as a child, and they gave him a different strain or something to smoke again to try and get rid of whatever he was experiencing. So, and that's culturally normal for us. Peer pressure, right? So we know that a lot of first use starts with people influencing you. Job stressors, unemployment, lack of adequate housing, advertising. So when you're driving down the road and you have a vaping ad, a nicotine ad, these are all things that make kids go, that looks like something to try. Social influence on social media, whatever the influencers are doing, the kids are doing. And we can use the Molly example there with Skeng and those folks. Yes, those folks. Ease of access. So, of course, the more accessible something is, the more you're likely to use it. And limited educational opportunities are linked to substance use disorders. Just a brief word on dual diagnosis. So, dual diagnosis means substance use disorder with a co-occurring mental illness. And as I said, it's pretty much 50%, but some populations have up to 75%. And some of the more common conditions would be depression, anxiety, PTSD, schizophrenia, bipolar, ADHD. It's not like I listed everything. And it's a complex relationship because we don't know if the mental illness happens first, then leads to substance use, or the substance use happens first and leads to the mental illness. And the other point too is that there's common genetic, psychological, and social factors for all of them. So there are genetic risk factors for, say, cannabis use that also give you risk factors for schizophrenia. The same adverse childhood experiences lead to both. So the truth is that it's complex, and in some cases it's one thing, and in some cases it's another. Sometimes somebody has anxiety, they smoke to feel calm. Sometimes somebody smokes, they were perfect, otherwise fine, they develop schizophrenia because of their genetic risk. But one thing is for sure is that you have to treat both of them successfully. So you can't have unmanaged anxiety and get the person off of the cannabis, then you have to have an answer for the anxiety. So a word on the Jamaican context, but Ms. Mitchell would have covered quite a bit of it. So I get to go through these a little bit faster. So she would have mentioned the 2023 drug prevalence survey already. I just highlighted the main points of it here. It was conducted among 12 to 65-year-olds, and it was related to the previous year that 60% of Jamaicans were using alcohol. So we saw that that was number one, which she had mentioned. 20% had used cannabis, 17% had used tobacco, and there were higher rates of use in males. We saw that 17% used alcohol in a harmful manner, and 66% of the past year's cannabis users were at risk for misuse. So there was more intense, more harmful use within cannabis users, and that could have been linked to the decriminalization, right? So lower risk perception says, well, it's not a big deal, so I can, maybe it led to smoking harder, right? Cocaine use is prevalent in less than 1% of the population, so thankful for that. Successive youth studies would have revealed early initiation to alcohol use at about age 13. You've seen this map now, so I don't necessarily need to go through it. We already highlighted the hot areas for alcohol, the Trelawney, St. Ann, and Kingston. Kingston and Trelawney leading the way when it comes to alcohol, cannabis, and nicotine. And the highlights in the fact that edible use had gone up, so that was something to flag, and the fact that high-risk ganja use had gone up.
It's interesting, Dr. Robin, you mentioned Trelawney, because even though it's a large parish, the population size is not as much as like St. James or another parish. So it's interesting that we have.
It has been brought to that question had been brought to me, and originally I couldn't answer why. But in looking on it, what I'm realizing is that it's a large farming population, which led me to look into what farmers do. So farmers have high stress, unstable jobs, and that is, so it is uncertain what the crop's going to yield and things like that. So it is a rural population, it's stressful, it is isolating, and then that population of people, or that group of people, are probably older, middle-aged men who are not likely to seek treatment. So they are likely to have poor coping skills, which is going to lead them to alcohol, right? So I think that it has to do with the rural population of men in that particular farming culture. That is probably why we might be seeing that. And then Kingston, the urban areas speak for themselves. St. Ann, maybe it has to do with the tourism, the hospitality industry, and just being having the proximity to substances.
And even though the stereotypical, but even among the hotel workers as well, it's a high stress job. So a lot of them have issues drinking, and some of them can actually be fired immediately if they're drunk on the job.
Right.
Right. So there are certain jobs like hospitality that lead you to having more chance of addiction. Is a Kingston not that bad?
St. Thomas.
Clarendon also has a money bus.
Anybody who live in Hanover?
They live in Hanover for sure.
Money bus is a
What is money bus?
It's a alcohol
drink.
Refinery.
Oh,
Ah. And St. Catherine is very high there as well. Yeah. Well, so looking at the specific trends that we're seeing at the National Council on Drug Abuse in terms of seeking treatment. All right. Somebody was asking about trends. This doesn't have to do with new psychoactive substances. This is based on the regular everyday substances that we see. So this is just showing the treatment numbers from January to November of last year. So we saw peaks in April and June, and then we saw a fall off in October, November, which is when Hurricane Melissa would have been. So people would have been seeking treatment less at that time, you know, prioritizing their basic needs. Men represent the majority of clients who come to NCDA. All right, this slide is busy, but basically what it's saying is that of these 2,000 plus cases that we treated, cannabis is the #1 drug of impact. So we continue to see that, meaning that is what people are coming for. So even though alcohol use is the highest, the thing that people are impacted by or affected by or need to come for is cannabis. And that also speaks to the fact that we get referrals from schools, we get referrals from the court. And so it's going to be illegal substances that probably drive that. But so cannabis is the #1, followed by tobacco and alcohol. But interestingly, there was a question about mushrooms. What is coming in fourth is vaping. So vaping, for people coming in for vaping, it surpassed those coming in for cocaine, mushrooms, and prescription medication combined. So mushrooms is really not representing large figures. There were 2 people who came in for mushrooms for that entire period. 3 people came in for prescription medication, 17 for cocaine, whereas 109 people came in for vaping. Go ahead.
That's cannabis use.
Sorry. Yes.
Has cannabis use increased since the legalization of it, or reducing the...
I like that you did this.
Yeah.
Decriminalization, it is not legal. Let us get that very clear, right?
Decriminalization. And we see that great amount of persons presenting with cannabis addiction.
So what the drug prevalence survey showed was that since the decriminalization, there was more intensity of use in the people, more hazardous use in people who were pretty much already using.
Right.
So it wasn't necessarily a numbers thing as far as I understand what the prevalence survey was. I don't have data from the people coming in for treatment cases, but what we saw was that people who were using were more comfortable to use and use more and use harder.
Maybe I don't understand the difference between decriminalization and legalization. I saw on the news the other day where the police, they were, you know, basically cutting down some acreage of marijuana.
Right.
If it's decriminalized.
It was not, so decriminalized means that there are not circumstances, there's, what is the word? There are a list of strictures.
Right, so
that farm was probably unlicensed.
Right.
So if you have a farm, it needs to be licensed with the CLA, the Caribbean. The
Cannabis Licensing Authority.
And so decriminalized means you can grow 3 plants in your home.
Oh,
so there are certain stipulations. So in 2015, they would have done a reform of the cannabis laws under the Dangerous Drugs Act, which allowed you to have 2 ounces or less for personal use. That's a ticketable offense, but not illegal. Then they also allowed Rastafarians to use for their religious purposes, and you have to have regulated growth based on the Cannabis Licensing Authority. So legal.
They have a specific section in
the act. Which is what people do. But they're also supposed to use it in their place of worship, as far as I know. Not just supposed to be on the roadside. And you're not supposed to use it publicly. Legalize would mean nothing. You just do what you please, grow what you please, use however. So decriminalize has rules.
Alcohol is legalized, but if you're under the drinking age, then you cannot have it.
Right.
Okay. It's interesting that alcohol is legal and it's the #1. And
no, it makes perfect sense that it's the #1 because it's legal.
Yeah.
So alcohol and nicotine are going to be #1 because they are legal, acceptable, accessible substances.
Right.
So one would say if you made cocaine legal, or if you made, you know, these hard drugs legal, you would see their numbers go.
Yeah. Well, no, you would see the numbers going up in people and you would see that they use.
That's a good point. All right. I don't have to go through these emerging trends but for reinforcement, right? Vaping, growing concern. As you guys are dealing with young people, adolescents, you are going to see that vaping is a problem. And vaping is a problem because it is nicotine, right? So it's not cute because it's in an electronic form. They are essentially smoking. And though they don't have some of the extraneous chemicals that are in a cigarette, they are still taking in nicotine, they are still undergoing the process of addiction. So it is not to be taken lightly that because it comes in acute form,
Right.
that is fine.
The vape is like a whole pack of cigarettes in one.
Right. So the face of substance use disorder is looking different.
Yeah.
So it's very concerning for our young people because back in the day you would say, don't take up coke, don't, you know, but they are doing these very subtle things that are very fashionable almost, right? You vape and you take a pill.
Like when you go to parties, it's offered to you, like you can purchase.
Right. So we're concerned about vaping, we're concerned about these synthetic drugs, the Molly, the ecstasy, and all the things that they're mixing in because these are unregulated things. So your young person may think that they are just taking a tablet and they're just doing a little Molly and it's laced with fentanyl and they overdose. And I don't want to say the word, but you know what happens. Because what you were saying, Ms. Mitchell was mentioning the lethal dose for the fentanyl, which is the 2 milligrams, but they make tablets that are 5 milligrams of fentanyl. And then the person doesn't have a clue because it's unregulated. They buy it on the street. They take 5 milligrams, one tablet, and that's it. So it's very concerning. And the new psychoactive substances, as we said, they are posing a significant risk because we are mixing all of these things together. And we went through the UNODC and what they're finding already. Look at us covering the bases. And polysubstance use is a significant concern. So we don't need to go through that again. Early warning system on drugs you were already introduced to, which is our network that we use to detect these new psychoactive substances and act on them. Okay, treatment. So what treatment looks like, generally speaking, is first you have to do withdrawal management, which is really primarily specific for opioids, alcohol, and nicotine. They actually have specific withdrawal protocols, specific medications that you use. There is no specific medication for cannabis withdrawal. There is no specific medication for cocaine withdrawal and other stimulants. But opioids, you have to give specific medications, the Narcan or some long-acting opioid to reduce the withdrawal symptoms. Alcohol as well, we have to use benzodiazepines to taper them off of the alcohol because they can develop severe withdrawal syndromes. Which are life-threatening, as well as opioids. Nicotine, we have to replace the nicotine with replacement therapy, and we have to help them with cravings and so on. But as I said, so when people come and they say they want a detox or a washout for cannabis, that's not a thing. It's not a thing. We can't wash it out. We can't flush it out. You just have to do the therapy, take time, cut it down. And people are mostly disappointed to hear that. I remember at UWI, people used to come and want to come to the detox unit, which is why the name has changed to Addiction Treatment Services Unit. Because when we call detox unit, people want to come and get a washout for their visa appointment.
Really?
Yes. Of course. That's very Jamaican. And you had to say, no, that's not a thing, but you can come for therapy, which provides great disappointment. So we manage the withdrawal state. Therapy is the primary means that we're using. So we use cognitive behavioral therapy. It's essentially getting somebody to move through the stages of the fact that they need to change this behavior, identifying how it's affecting their life, and then using different therapy strategies to assist them in reducing and eventually stopping this substance. There are medications, as I said, which are mostly related to withdrawal states, and we also have the management of the comorbidity. So as we said, if anxiety is driving the substance use, or the alcohol use, or the smoking, or whatever it is, or depression is the reason that they're smoking, we have to manage that. So we have therapies like motivational enhancement, so getting somebody to move along that stage to want to change, the cognitive behavioral therapy, dialectical behavior therapy, contingency management. So, rewards for meeting certain goals, and family therapy is important because oftentimes people with substance use disorders have disrupted family circumstances because of their use. So our treatment services now, we have inpatient or residential facilities. Now for a country of 3 million people, that's a low list, but that's what we have. Addiction Treatment Services Unit at UWI, they do inpatient, it's about 3 weeks for admission. Richmond Fellowship, which is Patricia House, they do about 3 to 6 months admission, so they're intermediate stay. Teen Challenge is long stay, so you can stay for a couple of months. Some people stay as long as 2 years. Some people get a job and don't leave. That's how Teen Challenge works. They get very integrated. It's a whole community. Public hospitals, which do acute management only. So you can't go to a public hospital and be admitted for any long stay. It's really just for the withdrawal for alcohol. What is it?
Quotation marks for acute.
For some persons.
Well, yes. Not usually for substance though. Usually for they would probably have a mental illness. And then private care, and then outpatient. You have the National Council on Drug Abuse. So we do outpatient counseling and treatment intervention, as well as broad prevention strategies. And the Addiction Treatment Services Unit has a clinic for outpatient. Mental health clinics around the island. They will do some amount of intervention, but that's not their area of specialty. They will more than likely refer to NCDA. And then private care. So we do have Narcotics Anonymous and Alcoholics Anonymous groups in Jamaica. Linstead. Yorton, Linstead, that area. And Teen Challenges in St. Anne. So you see how that is limited for somebody.
Yes.
Because I believe they do very good things, but you then have to move parish.
Right.
And people can't visit you the way that they would want to and stuff like that. So NCDA, just a brief word, we strive for a drug-free Jamaica. So that means eradication of substance misuse, not substance use. Doesn't mean we don't expect anybody to drink any form of alcohol. It means we want to reduce harmful and hazardous use in people, eradicate it. And we also do mental wellness promotion. So we do prevention programs. So we design and deliver evidence-based, relevant, culturally relevant programs that foster general mental wellness practices. And we're heavily involved in public education and awareness. So we educate the public about substance misuse and the dangers. And we're also promoting mental wellness generally. And then treatment and rehabilitation. So we facilitate treatment plans using counseling and rehabilitation. And we have counselors and psychologists for that purpose, for people who have substance misuse. And then we have case management officers who would be dealing with the psychosocial matters. We do research and monitoring, right? So we conduct and monitor and analyze trends in substance use in Jamaica so that we can drive program development and we can inform policy. We do not make policy. That happens in the law. We don't do that, but we inform policy and advocacy for persons with mental health, general mental health issues, as well as substance use issues. So in conclusion, substance misuse is very complex. It's impacted by many things, and then it goes on to impact many things. So it affects your mental health, it affects disease, crime, road safety, general productivity in your country. So we have to address the issue with a multi-pronged approach with interventions in multiple settings to target multiple groups and to therefore prevent misuse and maximize the health of the people. So that is it. Any questions?
We're asking in between.
Okay.
Pretty clear.
Pretty clear. And it tied in with yes. Good. All right. Thank you all for your attention.
Hi, afternoon. I have a question.
Hi.
I know of some local psychiatrists trying to integrate psychedelic therapy into their practice, whether it relates to substance abuse or even like PTSD therapy. Is there any general recommendation regarding that or no?
So let me go on the record and say that I am not making any recommendation about psychedelics in this session, but I will make a general statement that says psilocybin, which is the mushroom, right, has been found to have certain benefits in treatment-resistant depression and PTSD and so on, as you're saying. The challenge is that because of these genetic psychosocial factors, you really cannot determine someone's response. So there are people who have negative responses and it induces a psychotic episode in that individual. So it comes down to regulation. We have not yet reached a point of anything like that. You have to have it regulated. You have to have those specific guidance and circumstances under which that is okay. So in short, yes, there are benefits. However, it needs to be regulated if that is to be instituted, and there is a regulatory body formed where they are discussing what it would look like for psychedelics to be used. But it is not yet regulated and not yet fully approved in that way in Jamaica. I'll say that.
You said the regulatory body is formed or it's being formed? Or it's not yet formed?
They meet. They meet. It is formed and they meet. And so where they're at in that process, I don't want to speak out of turn. I'm not sure.
All right. Thank you so much.
As it relates to just piggybacking on what Steve was asking, CBD use in terms of in the management of persons with maybe like cannabis use disorder or even chronic pain and other stuff. Is it the same scenario with the other drugs in terms of the regulations and it being offered as a form of treatment?
So there's more regulation as it relates to cannabis and medicinal cannabis. There is, again, a committee that meets about the regulation of those things. So that is why, anytime anybody asks me this topic publicly, I'm like,
That's how CBD.
We do prescribe, people prescribe CBD now for anxiety and those things. And there is a body that needs to regulate that. I think that there is more that is to come as it relates to its regulation, but people prescribe CBD. CBD has many benefits, and there is a body to regulate that, but it might not be, I think I'll leave it there.
Oh, no problem.
Yeah.
Last question. A lot of patients sometimes ask, where they can get a patch. I usually don't know where to tell them. I just say go to a pharmacy. But is there like all pharmacies offer it, or there like a specific pharmacy? Okay, this is
nicotine. I think we have some of, I don't know that is that widely available.
Yeah.
Yes, you do.
You write down a prescription pad, or they can just go and ask for it.
I think you need a
cost of the patch may be a factor, so they will be.
Right, they have gum for sure, but for long acting, and the patch is not widely available because I would have asked a pharmacy just the other day, a popular pharmacy, and they didn't have it. So I think that there is a lack of long acting nicotine replacement. Some places have the patch.
I'm wondering if that, well, I guess the data would have to use the data to argue that. I'm wondering if that could be something NHF could subsidize on the card. But then it would have to go through this whole process.
I would say there's a lot to be done as it relates to being able to make certain interventions more accessible, because if you even look at, generally you wouldn't go to a health center and they're writing a prescription for a nicotine patch or a nicotine replacement prescription. So you would end up having to go privately. And that is not accessible to most people. So we need an accessible, treatment other than NCDA, which primarily works on therapy, but we're working on it. I'll leave it. I'll do that. I'll say that. We know that there are gaps in access to treatment and all treatments. Problem.
Thank you, Dr. Robinson Barrett. You guys learned a lot from her today. In fact, she shared a lot of new data that we haven't had an opportunity to see. So everyone, just before we move on, I'd like to thank Ms. Tamara Winter, Mrs. Tamara Winter. She's a member from Janssen Pharmaceutical, and they've been kind enough to provide refreshments for our workshop today. As you can see, she would have been here earlier. You would have signed the paper. So please give a kind gratitude to
The board is not kind, but happy. I'm happy to be here and to facilitate some refreshments for the session. And as Doc pointed out, I work with J&J where I do the line of CNS drugs. So the line of paliperidone, palmitate, and risperidone. So Risperdal Consta, Concerta, and Invega, the line of Invega. So we have Invega Sustena, that's once monthly. Invega Trinza, that's 3 times every 3 months. And Invega Half Year. Half Year is every 6 months. Half year. So Half Year is registered, but only available right now for private patients. We have to bring it in first to get a subsidy provided for private patients. As it relates to Sustena and Trinza, Sustena is on formulary, Trinza is in the process, but both has subsidy provided for private patients, and Sustena is in government. Where Trinza is right now, we can say that it's on formulary. However, the awards for new drugs has not been announced yet. The date has been pushed back to November of this year. So we're looking at possibly December before we have Trinza available to government patients. Yes. Right, so those patients would be seen every 3 months and not every month as it is with Sustena. But as you know, or may not know, you have to be on Sustena to move to Trinza. And you can be move from Sustena to Half Year. Sustena is just the base. So you can move from Sustena to Trinza or Half Year. Yes, but our next step is to have our patients being treated on Trinza, especially those who are in the field of working rather or school, so they don't have to come out ever so often to get their injection, because I can tell you the wait is long. When they do come to clinics, the wait is long, and sometimes the doctors don't come over in time. They show up before their doctor, you know. It's a long process. So we're trying our best, and they've been asking, I can tell you, oh Lord, but it's not in our hands really. But hopefully by the end of this year, we can be in that position where, you know, their visits to the clinic will be 4 times for the year and not 12. Yeah. Yeah, so this is me. My number is 281-0384. That is 281-0384. If you have any questions you need to ask as it relates to the line of paliperidone palmitate, or if you need some studies to be provided, any information you need, I am here. Yes, I have one. Oh, sorry.
Minutes, you know, bathroom break, grab a cup of coffee, and we'll continue for the last 2 presentations.
They have these studios.
All right, everyone, so we're ready? Back traffic.
All right, so we can start.
Great. So let's restart, everyone. So we have 2 more lectures. Dr. McCleary will do this, and then we'll do the last one. And we hope to get you out of there by 2:15 the latest. All right, Dr. McCleary, go ahead.
So good afternoon, everyone. As Dr. Lalonde just said, he wants to get you out by 2 o'clock. And it's now 1:20. So officially, he's cutting my presentation in half. So I don't know how I'm going to work with that, but I'll try to push. Hold on, let me just, I took off the mute. It's still muted? No, it's not. I'll try to push through with that time limit. In addition to that, I wear many hats today. I wear the hat of the doctor that works in corrections, right? So we'll be highlighting some of those issues which were already discussed in our prior presentation. And I am also the person that is presenting after lunch. So we know that the ethnic fatigue will be kicking in, but I'm just asking you to just work with me, all right? How do I go next? All right, so the presentation is on the relationship between substance disorder, severe mental illness, and violence, also known as criminality. So what is violence? Violence is actually a global concern and it affects everybody. You see it on the news, you see it in the newspaper, you see it on social media, you wake up, you hear about violence, you go to bed, violence, violence, violence. And I mean, if anybody's watching the news now, we know that the world is going through a violent pandemic, right? I don't know about, I don't have a master's in public health, but I'm just trying to use the term. So if I use it incorrectly, please bear with me. So the WHO defines violence as the intentional use of physical force or power, threatened or actual, against oneself, another person, against a group or a community that ultimately either results in or has high likelihood of resulting in injury, death, psychological harm, maladaptation, or maldevelopment or deprivation. So it's a lot that is saying, but it's just basically saying anything that causes harm to an individual. And it does not only have to be physical. So as I said before, it's a global issue and it affects everyone. No one is spared. And initially, when in the 1990s, the focus was more on how do we react to a violent act? How do we try to react to violence? And that was what WHO was focusing on.
However, as time has progressed, there is some evolution into what is it that we're going to zoom in on. So now there's more focus on it being centered around prevention. Why? Because of the ultimate impact that it has on one's health, the impact, the burden that it has on the health sector, the burden on the judiciary system, and ultimately the burden that it has on me in corrections. So we have already highlighted the key terms for substance use. So I'll just mention what severe mental illness is. It's a psychiatric disorder such as schizophrenia, bipolar disorder, and schizoaffective disorder that significantly impairs one's function and their occupational activities. And as I mentioned before, we're focusing on criminality, and it is any participation in any illegal act, including violent and non-violent offenses, and the contact with the justice system, whether you are arrested, convicted, or incarcerated. So, what's the focus of this presentation? For the time constraint, I'm just going to focus on identifying two major factors that play a significant role in the onset, precipitation, and perpetuation of violence in our setting. Also to explain the mechanisms linking the two to criminal behavior and discussing the possible approaches that we can come together in discussing to find amicable or appropriate solutions. So I know this is nothing new. We see this on the news quite often or from time to time where we're informed of violent acts involving individuals with a mental illness. But I must say that there are times when there are also cases where the alleged perpetrators are not mentally ill patients, they're actually the victims of other individuals. So they're not always violent, sometimes they are also victims. So the question is asked, are the mentally ill violent? Are the mentally ill at an increased risk of violence? Are the public at risk? And studies have shown that most violence in our society is caused by people without mental illness. And you can see, if you go into any prison, if you get any statistic, I'm certain the majority of persons that are remanded or incarcerated are not mentally ill. So in our institutions, we have about approximately 5,000 remandees and inmates. And we have approximately 500 persons who are mentally ill, who were sent for assessment, or who are being evaluated to determine whether or not they should be held accountable for the offense. So we can see that it's not just a case wherein all violent acts are associated with individuals who are mentally ill. So the majority of individuals with mental illness never engage in violence. They're at an increased risk of committing a crime, especially violent crimes on an average person. But when you look on the grand scheme, they are not as violent as the general population. So who are the individuals that are more prone? Who are the mental ill patients that are more prone to these incidents? Some individuals with specific psychiatric disorders, mostly the psychotic disorders, such as schizophrenia, schizoaffective disorder, and bipolar, not to mention those with some personality disorders and substance use disorders are associated with an increased relative risk of violence than persons of the general public. So it is basically saying that if you have a mental illness, there's an increased risk of you being more violent than someone who does not have a mental illness. But that is not a direct causal relationship to say that because you're mentally ill, you will be violent. So we have that myth that is out there that I'm a madman, so I'm afraid of him, right? But the reality is that someone who is properly dressed can come and drive up beside you in your vehicle and gun you down, and that person is not mentally ill. So serious violence is really among individuals with mental illness and does not independently predict future violent behaviors. So there are other predictive factors. Of note, untreated mental illness particularly those with psychotic symptoms like hallucinations, increases the risk of violent behavior. Now, what are hallucinations? This is when the person start hearing things, you know, somebody's talking to them, telling them, you see that somebody there? Don't watch them no good, them might try work against you. So they're hearing these negative thoughts that are coming in. And of course, that is now going to continue to let them feel threatened, right? So psychosis, specifically persecutory delusions, which as it says, persecutory. So the term suggests that the individual has this false belief that persons are plotting against them, they're spying on them, they're threatening them, they're trying to control them, and that is what is going to actually lead them to having some form of aggression because they feel as if they're at threat, right? So these are the significant factors that increases the risk of violence. So studies have revealed that only 3% of violent acts are attributable to individuals with a severe mental illness. So what happened to the 97%? Who are those persons that would be considered violent? The normal person. So the majority of mentally ill are non-violent, and because of their vulnerability, right, they are more likely to be the victims than the perpetrators. So with that, you think about the violence risk. It is very dynamic and it changes depending on your circumstance. It depends on your treatment. It depends on your mental state at the time of the incident and your social stressors that are happening. So one would ask the question, what are the risk factors for violence? What's going on here? Okay. All right, so let me work with this one. And I'm just going to pull a few from it. So what are some of the risk factors for an individual being violent? Having a previous episode of being violent in the past. That makes sense. If you have done it before, it increases the likelihood of you doing it again. If you thief before, you might thief again, right? So it happens for everyone. Psychopathy. If it is that you have a mental illness and you have the range way of thinking, your thoughts are not organized, you're very irrational in how you process, you have poor decision making, that would predispose you. Significantly, a substance use history. Right? So once you have substance use, that's a significant risk factor. Now, in our setting, we have 1 female prison and we have 9 male prisons. What can we extrapolate from that? Am I using the right term? What can we get from that? You have more males than females, right? And so it just shows that once you are a male, there's an increased risk. And also, the younger you are, you're more likely to be inclined, or there's a greater risk of you being more violent than an older person. Also, Dr. Robinson had highlighted childhood experiences, adverse childhood experiences. Those shape who you become in the future. Right? So that plays a significant role. And if you have a criminal history, that would predispose you. And there are other factors, but low socioeconomic background, you're unemployed, you're uneducated, right? Those are some significant factors that predisposes the likelihood of you being violent than the average person. So poor family support is another factor that most times is overlooked. And I already highlighted the psychotic symptoms, where when you have delusions and hallucinations, those are big factors. And again, I overemphasize substance use. Can't overlook substance use. So with that being said, trying to work with Dr. Lanoa this time, please tell me if I'm going too fast. Who are the most likely targets of violence by the mentally ill? Because if 3% is violent, I want to know what's going to happen with those 3%, right? So who are the persons that are usually the victims of those persons with a mental illness attacking, right? So a MacArthur violence risk assessment study was done And it showed that those closest to you are normally the victims, right? With persons with mental illness. Because if you think about it, the person that you interact with the most, that's where you're going to start having some negative thoughts centered around. Mommy, I think she's poisoning me off. I think she putting things in my food, right? They're trying to keep me down. You understand? So it normally occurs with persons in close proximity, or you're more closely related to them than Mr. Tom or Mr. John down by the shop, because you have more interactions with these individuals. So family members and friends, right, are those persons who are more at risk. And it tends to happen within the home because of closer interaction. So research also suggests that violence most likely occur in family where there are problems. I'm not saying it doesn't happen in a ideal home. And the question is, which home is ideal? Every home has challenges, right? But if it is that these mentally ill patients perceive that there is a threat within the home, and the threat can be just by what you say, you know, certain interactions. We can't bother this sometimes, you know, you just watch me. And just by those statements, these individuals can start harboring negative thoughts about these individuals or family members. Any form of hostility. I mean, I have a not a toddler, but you know, sometimes your tolerance level, it just hit a rock bottom, right? It's not that you're hostile, but you become intolerant, and you might say, just go do something, you know, just do something. So I think that with that, someone who is extremely sensitive, right, as someone who is mentally ill, may not be as tolerant and may be more sensitive to certain things that are said in comparison to someone who does not have a mental illness and say, all right, let's go take a chill pill. You know, you just kind of be worked up. So financial dependence. So persons who they are mentally ill, they can't work because nobody wants to work with someone who is mentally ill. For whatever reason, they never got to get all the they never got to get all their sexy subjects. So as a result of that, maybe they got ill when they were younger. So with that, they were unable to reach the stage that they could be properly employed. So they're more financially dependent on family members. And so you see that power dynamics coming out there, because every time I have to go to you for money, and because you're already trying to sabotage me and you're trying to bring me down, I know I have to come to you for money. So you can see where, you know, the dynamics can actually contribute to that. And just having a psychotic disorder as a diagnosis with substance use, which tends to happen, is quite common. Dr. Robinson had highlighted about the dual diagnosis between substance use and mental illness. So it's real. And of course, persons who fail to follow up. So if it is that they are mentally ill and you're not going for the regular checkup, what is going to happen to them? Their mental state is going to deteriorate. And then they're going to start attacking those that are closest to them. So the question is, or the statement is, mentally ill are more victims than villains. Many persons with mental illness live in very dangerous and impoverished neighborhoods, and as such, they are at a higher risk of being criminally victimized than the average individual. And they are also at a greater risk of being homeless. And Dr. Lalawani will shed more light on that, right? So I won't even spend any time discussing that. So some people, Mr. Fisher did a study and he made a statement, and I think it was very, very profound as he spoke to the socioeconomic background. Some people with severe mental illness may engage in offending behaviors because their poverty places them at risk of engaging in many of the same behaviors displayed by persons without mental illness who are similarly situated. So, in essence, that is saying, if we're all living in this area and we're all poor and nobody is working and everybody has to go around and beg people for money, the mental ill is going to do the same thing, right? Because of their social setting, right? So it forces them. Poverty plays a significant role in that. So in addition to these socioeconomic factors, substance abuse is a major determinant of violence. And whether it occurs in the context of a concurrent mental illness or not, it still plays a role. So it is being said that there's at least a 4-fold increase in violence likelihood when substance use is involved. So we can see that from this study, if you have a mental illness, there's an increased risk. But if there's a substance use on board, there is a greater risk of violence, right? So comorbid substance use may precipitate and complicate an acute psychotic episode, which alters the emotional response and disinhibits a patient's control of aggressive urges, leading to what? Violence, right? So that's just an idea. So moving on, how does substance use disorder promote criminality? At this time, I would have been asking some questions because I know y'all are brilliant, but I can't. So from a pharmacological standpoint, Dr. Robinson had highlighted how it works, right? But substances, psychoactive substances, it reduces your inhibition. So you're more disinhibited. Any and everything goes. You become more impulsive. There's nothing restraining you. There's no conscience. There's nothing that is saying that, no, this is not right. The super ego is gone to the wind, right? And as such, you have more impaired judgment because the brain is not functioning as it should. And that leads to increased aggression. And this aggression leads to violent crimes, which can be assault, domestic violence, homicide, in the context of being disinhibited or in some cases being intoxicated. And property and acquisitive crime, wherein because of your need for the substance, you start stealing, you break into people's houses, you start robbing to finance the substance use. And that also leads to you getting involved in drug-related crimes, such as possession, trafficking, and also dealing with particular drugs. So we'll talk about traffic-related crime. I'll just speak about the DUIs, which is quite common, and just disorderly conduct. We see a lot of videos of persons when they're intoxicated, they act out of character. And I'm certain many persons sitting here will reflect on some things that they're not so proud of, to talk about when it was that they tried something, right? So involvement in crime can increase exposure to drugs and also normalize its use. And this is showing that there is a bidirectional relationship wherein the use of drugs shapes crime, which we highlighted before. The substance use led to all of those criminal events that we highlighted a while ago, the violence, the assault, the robbery, the burglary. But at the same time, crime itself can also shape drug use. By you being involved in these situations, it also increases the likelihood of you forming wrong associations, and that perpetuates substance use. So this is a typical example of persons who will realize that substance use does not always cause all crime, but it amplifies the risk through different pathways, whether it is economic, pharmacological, or psychosocial. So now we're trying to wind down. We're going to talk about the merger between substance use violence and comorbid mental illness. Now, drug use disorders are associated with the highest risk for lifetime crime. And my master's students, lifetime prevalence is where if it has ever happened, right? Right. So drug use disorders are associated with the highest risk of lifetime crime, lifetime incarceration, and current legal problems. So it is the highest risk. So in essence, if you have a mental illness, you may not necessarily have a high risk for lifetime crime, but drug use disorders significantly do that. But furthermore, it says if you have a drug use disorder with a severe mental illness, particular a psychotic disorder, you're at a substantially higher odds of lifetime criminal behavior, incarceration, because of that underlying condition. So you have an increased risk than if you just have a mental illness or just substance use alone. It's like a combined risk. So substance use, especially within the forensic psychiatric population, is a key risk factor for violence and reoffending. And this indicates a need for an integrated service in prisons, probation, and community service, community settings. So I have a patient, he's 21, he has a mental illness, was diagnosed with schizophrenia, no prior forensic history, was about to be enrolled at UTech. I mean, everything was doing well. He's just one of those that he was early diagnosed, started treatment, compliant with medication, had a bright future, was in a good relationship, and he's just looking forward to enrolling in the UTech for engineering. He went to have a party. He partied with his friends. And at that time, he came home, and according to him, he overdid it. Had a lot of alcohol, and he smoked marijuana. He has not smoked marijuana for how many years since his diagnosis. So he was not having any cognitive decline. He was doing well. And Mr. Young Man decided to overindulge. He went home, right? Visited his girlfriend, was talking to her, and for whatever reason, he saw something around him. And in the spur of the moment, took up a knife and stabbed his girlfriend. Now this young man, who is supposed to be at UTech doing engineering, is now institutionalized, awaiting his trial. So I'm just trying to show you that this is real. Substance use, mental illness is a combination for a very poor prognosis. And just as it increases the lifetime incidence of crime, it also affects your future because you have a forensic history now. If you apply for anywhere, you have to say that you were charged for. You understand what I'm saying? So it has significant implications. So what's the way forward? As a psychiatrist, we talk about holistic health, right? Because we know that health is everything is in its entirety. So it's not just the biological, it's also the psychological and the social. So Dr. Adderley had highlighted some of the gaps and some of the issues that occur with persons who are mentally ill, especially when they're introduced into the judiciary system. Now, what are some of the present challenges that we're having? The reality is that the jails and the prisons are the key contact points for people with substance use and mentally ill illnesses. A lot of persons, as soon as they create an offense, especially if you're mentally ill, if there's an offense, they don't carry it to the hospital, they carry it to the police station. And the police slap you with a charge, and where do you end up? You end up in my institution. And when you come in my institution, the judge is going to ask for a psychiatric evaluation, right? And also to start treatment and to determine if he or she is fit to stand trial. So with that being said, many facilities lack access to evidence-based addiction treatment because the reality is that many persons, a large percentage of the population of individuals who actually commit an offense have a substance use disorder, right? So we can see that if it is that is not being addressed outside, it needs to be addressed inside and also when they leave. So a lot of times they rely on punitive responses that have been shown to increase relapse and recidivism. Because a lot of these patients come into our institution and we can focus on the biological, but the psychological and the social is still being affected. They're separated from their family. They're separated from their social support group. Their rights are being removed. It's just a complete culture shock. That in and of itself is a stressor. So this is highlighting that there are many challenges arising from the gaps in the holistic treatment of patients, especially when they enter the judiciary system. So this is the reality. A criminal offense is committed, psychiatric evaluation is requested. When these patients are remanded, more emphasis is on the diagnosis, the treatment, and their stabilization, because it is believed that if it is that their mental illness led to this condition or led to this offense, we need to nip that part in the bud. But a lot of times, what is forgotten? The substance use. What were the circumstances that led to the offense being connected? So institutionalized, these persons become institutionalized, and they're institutionalized for prolonged periods. Dr. Adderley highlighted that there are persons who are there for decades, and it is true. And they're there and they have very limited support and minimal psychological support because we are now bursting through our seams. Everybody that commits an offense, or the majority, they're not channeled into other outpatient care. They're sent into the institutions, and the reality is that there are already limitations, resource limitations, as well as not having adequate human resources to deal with these things, right? So we can see where they are sent, they're in the institution, families are now away. Eventually these relationships evolve. You were married when you went in, mentally ill. Eventually you realize that your wife sent you divorce papers or she just filed for it. She has moved on and you're still awaiting your trial. So these are some of the challenges that they have. Now, when it is that they have left the institution, there's still social issues. Homelessness. A lot of them, the life that they had before they came in is no longer the life that they're going back to. Unemployment, poor education, and once again, poverty. So we can see wherein, if it is that I'm still poor, I can't provide for myself, I have nowhere to live, what is going to happen? They may start reoffending again because it is now they're in survival mode. And when that happens, you realize that the cycle comes back. Recidivism. They come back in and it's again for the same thing and the cycle continues. So I'm just trying to show you that there are different facets to training or to dealing with patients with substance use and mental illness. And we have these challenges as well, right? Because the reality is that when they are here, we can primarily focus on the biological. The social support is not there. We have one psychologist for each institution. You understand what I'm saying? We have 2 case managers for the entire institution. So as they highlighted, you know, the steps for substance use rehabilitation, we don't have the resources for that. So these prolonged remand lead to social stressors, and it also exacerbates psychosis. They came in, they were medically unfit, and due to the prolonged stay, they also have cognitive decline and they remain unfit. Now, I will say though, when Dr. Adderley was highlighting about the reports not being sent, we as a psychiatrist within the institution, we wear many hats because we're also their advocates. And I'm certain you all heard about Noel Chambers' situation, right? So what we do is that we do the reports, but there is a gap between the reports being done by the correctional services and it reaching the judiciary system, the judges. there's a gap because that is brought and it is forwarded, but somewhere along the line it's not done. So we will have cases where these patients are seen every month, because I do it. I see them every month. And then it is said that you see that this patient has been here for 10 years and they have never gotten a review. And as was highlighted, every year there should be a review of the case to see what is the status of this patient's mental fitness to stand trial. So you can see that the gap is not just here, but the gap is even higher up, right? And it puts a lot of pressure on us trying to be advocates of patients, but still having our hands tied. And it can be frustrating at times because there are many persons who are currently fit, are assessed as being fit, the report is done, it is sent, but it has not been received. Their legal representation, because they are poor socioeconomic background, they can't afford Peter Champagny, they can't afford the one that Nita, right, or Kinghorn. So all they have is a legal aid. The legal aid is not getting any significant remuneration for their case. So what happens is that it keeps passing around, it passes around. So these patients will fall through the gaps and fall through the cracks. So the pressure is on us now to bridge between the different systems at play to advocate for these patients. So we do our part, but it doesn't end there. So we have patients who are fit and eventually become unfit because of just the delayed and the social stresses and all the problems that have been occurring. And then last but not least, for persons who are mentally stable and have been assessed and are stabilized and are released, there is no effective system to ensure follow-up within the community because there is no liaison officer, as in other first world countries, that serve the role of connecting persons from the penal system to the community. You will write a referral for continuation of care, and it does not reach anywhere. So you see now what you're trying to intercept to undo that cycle, because the other powers, the other parties within the system have not been fully aware of what is happening. We end up having these patients back at square one. So it can be very discouraging when you realize that the cycle just continues. However, studies have shown that there are evidence-based interventions linked to crime reduction. And I think Dr. Robinson had highlighted it, medication-based treatment for substance use disorders and mental illness in and after incarceration. Behavioral therapy, case management, which does not stop in the institution, but when they leave. But I highlighted that you have 2 case managers per institution. And we have, in some cases, nearly up to 2,000 patients in the institution. So you can see wherein we have limited human resources, but there is a large demand for these services to prevent reoffense by these patients getting the proper treatment. So this is why we're having this discussion, because you are the public health persons who are going to be a part of the patient advocacy in getting right. You are going to be the trailblazers in creating policies and speaking and bridging the gaps and forming connections between inpatient and outpatient care, because it is needed. These interventions are present at this point in time, but it is not enough to meet the demands. And that's why we need more persons involved. And it has been shown that persons who get proper treatment and proper intervention, there's a lowered risk. So the biological approach, which is what I can do in the institution, is that we try to optimize them medically, right? We give them antipsychotics to get them as stable as possible. But that is from a psychiatric standpoint, trying to deal with the psychosis. We may use oral medication, but long-acting has been proven to be very effective because when you're remanded, you don't know if you're going to come back after you go to court. So it's very unpredictable whether or not these patients will return if they go to court, especially when they're here for psychiatric evaluation. So the future of the patient is dependent on the judge. And we do not get the memo. What is the outcome? The memo is when I call for the patient and the patient is said, did not return from court. So you can see that with that, every time the patient goes to court, I have to write a referral because just in case you don't come back, I want to ensure that I would have done my part to try to ensure that he or she is there. So that calls for the reason for the long-acting injectables because that stays in the system for a longer time. In the prison system, we use Invega Sustenna quite often because it has been shown that when it is used in earlier stages of the onset of psychosis, it has a better prognosis, especially in younger individuals. And if you remember the risk factors for violence, we mentioned that younger males are at an increased risk. Persons with a psychotic disorder are at an increased risk. So these are some of the factors why we will use the Invega Sustenna as well as the regular Modicate and Clopixol depot. So this is just a study that speaks to what I mentioned just now. So this is where we're at, your role. We want to reach a stage where we can start doing surveys and track substance use disorders in and out of the prison. And also other mental illnesses because we see that there is a dual relationship as it relates to it increasing the risk of violence, right? Also tracking the crime, recidivism, and the health outcomes of these patients. Last but not last, program evaluation, whatever is implemented, the diversion programs, the prison-based treatment, the community integration, is it working? Is it not? What can we do? And also just advocate for integration of substance use disorders and mental health services into the correction system because we don't have an addiction specialist. So if we don't have an addiction specialist, what is that saying? We cannot treat substance use. And the majority of patients that are presently in the corrections, there's a high prevalence of cannabis use and tobacco use. The alcohol is there, but it's homemade. So I don't know if that is considered as straight alcohol, but it's homemade. But cannabis use is still there. Please do not ask how it is happening, but it happens, right? So you can see when I am trying to treat the psychosis and to get them optimized, these access to these precipitating factors, such as the cannabis, is going to actually affect their mental state and cause prolonged stay. All right, so what else can we do is reinforce existing interventions, improve rehabilitation programs in and out of the penal system, encouraging robust community support. No one is an island, no one stands alone. Everybody has to work together. The church, the families, the community, the youth groups, everybody has a role to play with persons who are facing challenges because most times violence comes from persons who are facing challenges, whether at home or due to their low socioeconomic background or due to their mental illness, whatever it may be. The fact is that by having a body system and having a supportive environment, that can actually assist. And last but not least, just mental health awareness campaign and sensitization to the services that are available when they leave our institutions. So what are the take-home points? Anybody? It's there. So it was supposed to have been point, right? So the take-home point is that once there's psychosis, there's an increased risk of violence, right? Substance use disorder even exacerbates it, right? So when it is combined with a mental illness, there is even a greater likelihood of violence. Despite being mentally ill, the socio-demographic factors, the economic factors, the social factors contribute significantly to violence more than mental health factors. And that was on the background that I said that persons who are mentally ill only commit 3% of the offenses in the overall general population. Continued psychiatric care and substance abuse treatment should decrease the risk of violence, right? But that comes from collaboration with all the different stakeholders. And last but not least, public health-oriented approach will be more effective than punitive strategies. So just sending them to the correctional services for drug rehabilitation makes no sense, because we cannot do drug rehabilitation. All we can do is maybe cut down the access. So when you could smoke 3, 4, 5 space when you're out in civilized in society and doing as you please, it is not as accessible. So to that extent, I can say that we're doing way better than before. So that concludes my presentation. Any questions?
Quite interesting, but being a psychologist, you ever been attacked?
No, you know, it's interesting that you ask, right? I've never been attacked by a mentally ill patient in the institution. But when I was working in the hospital, I was attacked before. So, and I think I erred on that side because I never knew that that patient was mentally ill. So, you know, when you know an individual is mentally ill, you're kind of a little bit more careful.
That brings me to the next concern I have, because I don't know when one of these patients is really, because, okay, being in a hospital and you have some patients who is, and you said these persons are, you won't attack or cause violence unless they, you know, they think they are threatened or
right.
But some amount of fear, because I'm not sure when one of these persons may actually snap at you.
And that is understandable. And I'm not saying that you are just going to go freely and not have some form of caution in how you interact with them. But the general perception of the public is that mentally ill, once you're mentally ill, you're violent. And that's what I'm trying to remove, that myth and misconception. However, the studies showed that there's an increased risk of violence than the general population.
Sorry, the studies measure this increased risk using the violence risk factor.
Right. Yes.
So it's just basically that because of the socioeconomic.
Hold on, you're asking if it is that they just use the violence risk factors,
right,
for so they use the mental illnesses, right? The psychotic disorders, those are one of the main ones, as well as their socio-demographic backgrounds, right? So those were, because the studies have shown from decades up until now that is a common, it keeps on repeating in all studies that these are the factors: poverty, lack of education, being male, having a mental illness, a psychotic disorder. So I think if it is that they're going to try to replicate a study in their environment, they're going to maybe use previous variables that were shown to have those risk factors so that they could assess and also compare to other studies.
So in essence, you know, it really comes back to your environment.
Yes, your environment plays a significant role. So in essence, it starts at home, right? It starts at home, within the family, then in the community, then in the society at large. It starts there. So we can't overemphasize the need to encourage adherence with medication, because that is important. If you have family members that are non-compliant with your medication, you have to collaborate with the community mental health services to get them stabilized, because when they're mentally ill and they start having psychotic symptoms, that is when there's an increased risk. So that is the crunch that you have to focus on.
I'm just listening to all the presentations, and I've noticed that most times we say that these people, one of the risk factors is because of their low socioeconomic status. But what I am seeing now and hearing on it is not only to lower, I see people who are up.
It's not only.
Most talk about persons who are in the low.
It's not only, it's just that based on the evidence, it is showing that yes, it is more, the majority.
We're missing those that are in the.
No, but normally though, they're national samples, right? So they have a large cross section of participants. So it's from the sample, right? Because most of their national ecological assessment, ECA, they normally use those assessments to determine what it is straight across the board. So it's not specific to downtown. It's straight across. Just as though Gabby had highlighted that when they do the substance use, the national survey is from all parishes. And so there's no element, so to remove all element of bias is for everybody.
Education, persons who are highly educated, and they're the ones that you're not paying attention to them, and they're the ones that will kill you.
No, and I agree, but the problem is that it is showing that the studies have shown that there's an increased risk more in those who are uneducated, because they aren't able to provide, they aren't able to be self-actualized, they aren't able to be independent. So that is a contributing factor. But we see crimes going straight up the ladder and coming right back down.
You see it in your workplace, you're working with persons around you and you don't know.
We see it at all times.
And they can do so much harm, and you don't expect it because you're not looking at that person.
That is true. However, I don't want you going around and you see I realize that you might have the potential, of being violent. I just want us to have the general view, right? But I appreciate that question, because violence is really no respect of persons. Mental illness is no respect of persons. And I said to persons that a mental illness is just like any other chronic illness. You can't pick, choose, and refuse if you want hypertension. You can't pick, choose, and refuse if you want diabetes. But if it happens, you have to just take your medication. And from time to time, your pressure may be elevated. Just as though if you may have 1 or 2 hallucinations, but that doesn't mean that your life is over and you cannot be of any use to society. So, ladies and gentlemen, if there are no other questions, thank you so much.
I have one more question. Sorry to keep you there.
Okay.
You had brought up the case of Noel Chambers, and so I did a little bit of reading around it, and I saw a statement by the Minister Without Portfolio that come out afterwards in 2020, and they said that there is going to be an increase in the psychiatric staffing. Do you know if that actually happened afterwards?
So due to Noel Chambers' situation, I got a job.
Oh,
right. So
okay.
So at that time in Noel Chambers, there were only part-time or sessional psychiatrists. So these are persons who were already employed into the government, but they were doing sessionals. Since that situation, there has been an increase, or they revisited the need, and there are at least 9 positions for consultant psychiatrists at this point in time. And we have already filled 6 or 7. So from a very unfortunate situation, there was some form of positive reactive formation. And as such, there are so many other mentally ill patients who have benefited from that, where there are no persons there who can advocate for them and can treat accordingly.
Thank you so much for answering that question.
All right, thank you.
Thank you, Dr. McCleary. That was wonderful. Guys, as you would have seen, it's quite strategic in terms of the topics that we're doing today and the sequence of the topics. I mean, Dr. McCleary captured for you in her own usual style what's the current situation and what the progress has been and what needs to be done. And certainly from an advocacy point, as well as from an interventional point, there's a significant role for public health to fill these gaps, because all of these issues that we've mattered or we've discussed so far are in fact, they are public health issues, yes? So this last presentation now is really bringing us home in terms of that intervention. We talked about the individual intervention that you can do in your own home, in your community. We've talked about what we can do within the institutions, like with Dr. McCleary and Dr. Adderley and Dr. Robinson. But today, I'm going to talk about the last one where, what about policy? Policy and legislation, because all of it works in tandem to effect the change that you want. And so maybe just shedding a little light on this last topic, which is quite unique. I'm looking at cannabis decriminalization and implications for public health. The reason why I chose this topic, of course, you heard Dr. Robinson mention that in our society, in Jamaica, we're very unique. All over the world, globally, alcohol followed by tobacco. This is the only piece of rock in this globe where it is alcohol followed by cannabis. I want you to think about that as we go through this presentation. So let's start. Historically, I've included this slide because we have to appreciate what the role of cannabis is here in Jamaica and the Caribbean, right? Historically, cannabis was endemic to the eastern part of the world, parts of Asia, Africa, and Middle East. It was used very much as medicinal. It was used very much in religious and spiritual practices. Now, in the 1920s to 30s, that would have been the time when we would have had indentured laborers, particularly coming out of India and coming to the Caribbean and settling down, and they would have brought their cultural and spiritual practices, which would have included the use of ganja. And of course, there's this very strong religious relevance in Hinduism. And you can imagine, as any particular culture, when you come to a new area, there's a process of acculturation where the practices are now shared within that society. And at that time, in the 1930s, in Jamaica in particular, there was a high level of social disenfranchisement. At that time, you would have recalled a lot of the social justice issues that were being pushed by Marcus Garvey. And at that time, there was an embracing of ganja and an integration into Rastafarian religion. Now, I mentioned that because think about that. That's almost 100 years ago. We're now what, 2026. And since that time, globally, cannabis has now become the most widely used drug in the world. The last World Drug Report of 2025 highlighted that it's used by 240 million people between the ages of 15 to 64. And for researchers, when you look at that age group, you're looking at what we call that adolescence entering into the emerging adulthood, followed to young adulthood, middle and older adult. That's why the retirement age is 65 and over. This here would be considered the working class, or 5% of the global population. Since 2010, and I've chosen that particular date because the research tells us that Since that time, in the last 15 years, many countries have chosen to either decriminalize, legalize, medicalize cannabis use. And so it's not surprising that you would see an increased prevalence. And in fact, it's almost 25% more. And now, today, represents the #1 substance use disorder in 40% of countries worldwide. And I use that because you would have heard from Dr. Robinson about substance use. That's persons who use, substance misuse. But when you talk about substance use disorder, the word disorder indicates that there's a dysfunction. And it's a clinical diagnosis that highlights the fact that your substance use has reached the level of such heights that you no longer function to the best of your ability. There's social and occupational dysfunction. So we're not just talking about people who use cannabis. We're talking about people who are impacted by cannabis to the level that they are now disordered. So we ask ourselves why. I've already mentioned to you about the policies and the legislation, but we've also seen in the last 15, 20 years, there's a renewed interest in its medicinal value. It is not to say that there are not benefits to cannabis or medicinal cannabis, but there are very clear indications. Studies have shown that the use of medicinal cannabis is proven with certain seizure disorders. One particular one known as Lennox-Gastaut seizure disorder. It has been useful in the treatment of palliative care for patients with cancer, especially when you're talking about the hyperemesis syndromes, such as the vomiting and the GI symptoms. But with medicinal cannabis, there are clear indications. There's, of course, an illicit drug market. You heard Ms. Mitchell so nicely explain to us about the transition points. We're Jamaica, we're sitting in the middle of the Caribbean Sea. We are the fulcrum point coming from the southern part of the world. And when it comes to us, we either take it up to the north or across the Atlantic Ocean. So of course, when the substances come to our shores, there's going to be a spillover effect. Not everything is captured. I mentioned about the political and social agendas. Of course, think about it. We talked about decriminalization. We talked about legalization. We talked about medicalization. These are all in some way or have been shown to be associated with perhaps a political agenda of whichever country it has chosen to do so. And certainly at the time when they were thinking about these agendas, it was thought that, well, maybe this is the green gold. There might be an economic boom. And there is a way that it can happen when you think about a well-regulated industry contributing tax revenues. But we know in a lot of countries, there's still a partial position when it comes to where the funds are coming and where they're going. So we have a problem. Or maybe we have more than one problem. Since that period of time, there had been a global shift in legislation. These are some of the problems. I call them the 6 Ps, the 6 problems. 1, prevalence. Adult populations show an increase in both the frequency of use and the number of cannabis-related hospitalizations. 2, there's been an increase in the availability of high-potency THC products, which increases the risk of mental health illnesses. For a lot of persons, there are numerous studies that have been shown. And I'm telling you guys now, because I'm pretty sure this is not part of the public messaging, but maybe it ought to be. THC potency, high potency, is considered anything over 10% of THC. If you go to any of these herb houses and you look on the merchandise, they have to disclose the THC, but you'll see product as low as 0% to as high as 25%, 23%, 30%, 18%. Now, why I mentioned about high potency cannabis is because the studies are unequivocal. In the last 3 years, numerous studies have been published, including in the Lancet, that there's almost an increase of about 5 odds of getting a psychotic episode if you smoke high potency cannabis of greater than 10%. How many of you guys knew that? But you don't see that written on the cannabis product, do you? That if you smoke greater than 10% THC, the risk of you having a psychotic episode is 5 times more than the general population. There's problematic use. We define problematic use as cannabis use addiction. Increased rates. Pediatric exposure. I'm sure you guys recall the travesty that happened in St. Anne a couple of years ago. But since legislation has been favorable, all over the globe, there have been increased rates of accidental cannabis exposure in children, especially edibles. I recall somebody had asked about the packaging and the child proof to Miss Mitchell. And all she could do was just smile. Perception. Reduce perception of harm. Of course, if I'm going to legalize it, if I'm going to decriminalize it, then to the common person, the lay person, they're going to think, well, something can't be wrong with that. It's legal. It's decriminalized. So the perception of harm reduces. And so therefore, younger people are going to be more likely to start at an earlier age. And that's going to lead you to using it at a heavier rate. And we talked about poor driving. Increased rates of cannabis-related driving impairment, accidents, and fatalities. What about here in Jamaica? We talk globally. I remember this headline. I used to work at St. Anne's Bay Hospital 5 years. And I was shocked to hear this because at that time I recall calling my colleague down there and they told me about 60 children had been brought in. At least 5 had become critical. Is it a problem? Yes, man. The same problems I highlighted globally are here. And I'm going to show you the studies. Pediatric exposure, we talked about it. You see the headline. Potency, poor driving, polysubstance use, and problematic use. This is the first paper, Current Trends in Adolescent. This was done by Miss Atkinson, Professor Abel, and Miss Whitehorn-Smith. Almost 10, 11 years ago, National School Survey data showed that 10% of children had engaged in past year cannabis use, what we call chronic cannabis use. And the age of initiation was 12 years old. You know what that means? Just in case persons don't understand, your brain, the human brain, continues to develop up to the age of 25, what we call neurogenesis. It keeps fulfilling its potential. It doesn't stop up till that age. Now, if at the age of 12 and 13, I'm putting cannabis of high potency with different other substances in that little 12 and 13-year-old brain that's currently developing, how the hell is that brain going to develop to the way it should have developed and to its maximum potential? That's the problem. This was another paper that was written post-decriminalization using the 2016 National Drug Survey, which was our first drug survey. That had almost 4,500 people that were interviewed. And what they found was that the recent decriminalization had had a positive association with increased likelihood of first-time use and overall use amongst young people. And that's critical because this study was actually done 1 year, approximately 1 year after the new decriminalization laws came into effect. Somebody had asked about it because what would have been great would have been if we'd had earlier studies to show and then compare it to after. But guess what? We did this study in 2016, and you heard Ms. Mitchell and Dr. Robinson talk about the one that was done just a couple of years ago. So we do have an opportunity to compare 1 year post-decriminalization versus almost a decade after. Yes? Marijuana use and its correlates among school-going Jamaican adolescents. This was another paper that was done 2 years ago. And what they found was that there were increased rates of loneliness, suicidality, physical tasks, being absent from school, starting sexual activity early, parental use. These were all associated with a higher cannabis use. So I've talked a little bit about the pediatric and the youth. Now let's talk about potency. This was a wonderful paper that was done right here at our university looking at cannabis edibles. And the edibles that you see in the market come in the form of baked goods, candies, frozen foods, drinks, all the things that you like to think you can just go in a gas station and pick up. And what did they find? 86% of the samples that they had investigated were poorly labeled, and not one of them were childproof. No wonder children have exposure. The highest percentage of the THC were detected in cookies and brownies. Now you tell me who's going to say no to a cookie and a brownie? Half of us still eat Oreos with milk every night. 30% of samples had levels greater than the 10 milligrams, which was recommended dosage. You're going to see where we're going with this, because it starts to tell you a picture. So what they did is say, okay, well, let's look at the potency of these products. There were 300 products that they had collected between 2014 and 2020. So just before decriminalization, and after. And what they found was that the potency ranged from as low as 0.02% to as high as 36%. And you guys just recall that I told you anything greater than 10% is associated with a 5 times increased risk of a psychotic break. You start to realize, not so well regulated, is it? Drunk driving and drug driving. This was a paper that we had put out using the 2016 data. You would have seen that in the 23 data set, they mentioned that drug driving had decreased. Well, for this particular paper, what we were able to do was to identify out of those who use drugs, because drugs would have been cannabis, methamphetamines, etc. But we were able to actually stratify those who were cannabis users out of the total drug population. There was only about 5 or 6 people that used cocaine or meth. The majority of the persons were drug driving to the use of cannabis, not coke or meth. So, you know, and it makes sense. That's our second used common drug here in Jamaica. But what we found was that 2 in 5 who currently use cannabis admitted to driving under the influence of cannabis. And 4 in 5 who currently use cannabis heavily, which is defined as high-risk cannabis use, or using more than 20 days in a month, admitted to also driving under the influence of cannabis. And look at that last finding. The risk of driving under the influence of cannabis was predominantly amongst young adult males. Those are persons between the age of 18 and 34, and who happened to be the main breadwinner of their home. They were the head of their household. Now you think about that for a second. You got the head of the household who's making the money, bringing in, taking care of the family, admitting to driving under the influence. And of course, it's not unsurprising, because during the time of COVID, leading up to COVID, go check the facts from the Road Safety Council. The road fatality rate continued to increase from 2018 to 2022 every year. Very surprisingly, during COVID, when we were in lockdown, we had more people dying by the road in 2021 than 2020. That makes sense to you? We were in lockdown, but yet we had a higher road fatality rate in that period. And in 2022, it was higher than 2021. In fact, I remember reading an article saying that the insurance companies reported a higher premium payout during COVID than in non-COVID years. But I thought that we were in lockdown. And it wasn't lost on me that when I was reading the business news at the time, that I won't call no names, but at least 2 distribution alcohol companies reported record profits. But I thought we were in lockdown. There were no parties. But people were drinking and smoking at home. Because we were socially isolated, we were lonely. Yeah. Let's take it a next step further. You would have heard about polysubstance use. This was a paper that we had done a couple of years ago, and we were able to identify from that similar drug survey that 1 in 5 Jamaicans identified as a polysubstance user. Now, this is critical. For public health, it is critical, because here why. The studies are unequivocal. When you use a single drug versus a multiple drug, which is 2 or more, that the risk of mortality and morbidity is 3 times higher with a polydrug user in comparison to a single drug user. So if I'm telling you that people who use more drugs or use multiple drugs are going to have more morbidity and more mortality, isn't that going to put a strain on the public health system? How often have we heard about polysubstance use? How many people here heard about polysubstance use before today? You've heard it before? How many people didn't hear about it? It's the majority of y'all. Y'all don't hear about it because they don't say it as much. Sometimes I wonder when I see the public education and the promotion messages, we talk about tobacco, we talk about alcohol, we talk about these in isolation. But we need to subsume the polydrug message as well because that carries a significant risk. Yes, ma'am. In this study, the 3 most common drugs, tobacco, alcohol, and cannabis. In fact, the combinations were predominated by cannabis. You heard earlier, alcohol and cannabis is more here than anywhere else in the world. Just to give you an idea, that triple combination of cannabis, alcohol, and tobacco was seen in 7% of drug users. That's actually 3 times higher than all of Latin America. There was a publication that came out just about 8 years ago that looked at almost 20 Latin American countries, and the highest prevalence of that triple combination was 2.9%. I think it was probably Chile. Jamaica blow past that. We were at 6.9. And we're a small little country.
Did you differentiate between grabber or the smoking cigarette and the cannabis cigarette?
No, we just spoke more. We spoke about tobacco, and in the study at that time, it wasn't differentiated by grabber. It was differentiated by nicotine. I don't think it was in terms of grabber. It was more cigarette use or tobacco use.
So essentially, you're measuring the smoking.
Yeah, because at the time when they had asked, like you see with the new drug prevalence survey, I think they actually asked a little bit more about grabber. But in that time, they were just talking more about tobacco. So it could have been interpreted as cigarette or grabber use. Yes? Yes.
I thought grabber was tobacco. They're not the same? Oh, okay.
No, grabber is tobacco leaf. So if you're strictly, the difference is you're smoking a whole cigarette that is only tobacco, whereas strictly grabber, the stuff is mainly marijuana. Right.
Correct.
Yeah, grabber is a tobacco. It's not. No, grabber is tobacco leaf.
Yeah.
They cure it, so it's. No, that's why they crush it. They crush it. The lives are fine. Crush it up and give it to sprinkle. But it's when you look at grabber is a leaf. It's tobacco leaf that they cure and mold out.
Yeah.
It's good. Take a look at this slide now. This was another study that was done just after, looking at psychosocial factors of singular substance compared to polydrug use. And what we found was that decreased risk perception, the starting cannabis in childhood, which would have been between 6 and 11, or in adolescence, which would have been between 12 and 17, and having easy access to cannabis all increased the risk of polysubstance use. And what's even more critical is that using alcohol and cigarette did not predict polysubstance use in Jamaica. So you got the young kid that would drink the liquor or have a cigarette, they weren't likely to go on to become a polydrug user. But if you started using cannabis at an early age between 6 and 17, yes, you were the one that were more likely to become a polydrug user. And then this most recent paper that we did just over a year ago, looking at problematic cannabis use. So what we were able to do was to actually now talk about persons who met the criteria for cannabis addiction. It was almost 790 people in that population survey who have been chronic cannabis users, meaning they use in the past 12 months consistently. And when we analyzed that particular cohort of persons who were not experimenters or a one-off user, but people who are habitual users using more than 20 days for the month, we found that 1 in 2 reported having cannabis addiction and that they use at least 2 spliffs a day. That's significant, because what that tells us now is that when people use 2 or more spliffs a day, you're at a higher risk of developing a cannabis addiction.
Cannabis addiction?
Yes, that's what problematic cannabis use means in this case. So it's not just the experimenters, yes? So again, similar to polysubstance use, there was an increased risk if you started at a young age in childhood and in adolescence. And of course, there was increased risk among those who had easy access to cannabis and reported a high need for treatment. This was a very important point. You know why? Because in that particular drug prevalence survey, the majority of the population did not know what the NCDA stood for. They just didn't know what it was. But 80% of these persons who are chronic cannabis users knew exactly who the NCDA was. You know why? Because they started to recognize they were having a problem and they were trying to get information on how to get help. So while the mass population were not aware about them, those who needed their help found out about them. So these are all public health issues. There are priorities. And so it's important for us to now think about mental health in a preventative way. You guys would have attended my first lecture on public mental health. And while we can talk about primary, secondary, and tertiary, I really try to hyper-focus on primary prevention simply because sometimes that's what you have to do. You have to take the problem away from the mass and create a solution at the top. And that's where we go back to policy and legislation. 1 year ago, the WHO launched new guidelines to help all countries reform and strengthen their mental health policies and systems. It's a wonderful book. I haven't finished it, but I would recommend that if you get a chance, you can skim through this book. You know what they suggested were their 5 key policy changes? 1, service organization. So you want to strengthen community mental health services, take the people out of the asylums. Workforce development. Let there be a multidisciplinary approach. Let it not just be the psychiatrist working in a silo. Let the psychiatrist work with the mental health nurse. Let us work with the social worker. Let us work with the psychologist. Let us work with the public health professional. Let us work with the financiers. It has to be a collaborative stakeholdership. You must move from a patriarchal system. This is not the old time where you must move from a patriarchal system. So we promote more patient-centered or person-centered care. That's including recognizing the rights of individuals, yes? And as we would have learned, we want to focus on social determinants because we realize that if you fix the problem at a social level, the person may never go on to develop an issue. I always ask the residents this very simple question and the students. If I take a 15-year-old boy and I put him up in Cherry Gardens, where he has a roof and shelter, electricity, light, water, gets 3 meals a day, no gunshots around him, and I compare it to the same 15-year-old who's down in the ghetto, down in the garrison, he got to sleep under his bed because the gunshots pop off every night. He gets 1 meal a day. He can't get running water. Who do you think is more likely to have a mental health problem or develop one? The second one, right? So you realize the importance of the social determinants or the structural determinant in preventing the problem before it occurs. And so that brings us to the last point there, leadership and governance, law reform. Sometimes you have to take that decision. And here's why I brought this up. So anybody familiar with what Thailand did recently? In 2022, Thailand decided to legalize cannabis, opened up their cannabis industry, made them a whole lot of money in the tourism market for sure. But then 3 years later, Thailand's moves to delegalize weed and major drug policy U-turn. Just last year, they're the first and only country. In fact, all the other countries that have done some level of legislative reform are just sitting and watching the experiment to see, well, is this the right thing to do? And look, why did they recriminalize? One, increase cannabis-related emergency visits. There was an increased concern about mental health effects because you had more people presenting to hospital with mental health issues. You had increased public consumption in tourist areas, of course. And that allowed you to introduce new drug-forming habits, yes? Cannabis was being sold near schools. Edibles resembling sweets and vapes had become widely available. You know there were no potency limit because they had no oversight bodies regulating the potency. There was increased youth exposure. High potency products were sold without warning. What do you guys really think? Sound familiar?
think we have all those problems here in Jamaica.
Exactly. That's right. Think about it. There's a reason why I showed you those studies. You know, we use data to help us make decisions, yes? Well, you got the data. So, my final thoughts. Legalization should include a complex public health process. Public health, you got to be a part of the decision making. Because improper implementation has clear risks. When Thailand did what they did, no regulating body, nothing to hold them accountable for potency, no cannabis sites for persons who could not stop but needed harm reduction. Not enough addiction resources. As you would have heard, Dr. McCleary mentioned, we have only 2 addiction specialists in the island, both who are about to retire in 3 months. How many addiction units do we have? 1 inpatient addiction unit at University Hospital, which means the man out in Westmoreland have to drive 4 hours to come in because we only have 6 beds. What about drop-down centers? We have Patricia House, we have Teen Challenge, but that's it. Patricia House is in Linset, Teen Challenge is in Monique. It seems so quite ironic that the West seems to be left out yet. When I first moved to Jamaica, I always heard about the weed in the West. So why is it important? Because if you have a well-regulated, well-resourced legal market, it can reduce harm. In other words, if we took the time in terms of our legislative reform to build out all the adjunct and allied health arms, ensuring that we have the resources in case there's a fallout, that we have accountable regulatory bodies, that we have laws that stipulate where cannabis can be smoked, where it cannot be smoked. Nowhere that you can have edibles and packaging that are not child-proof. That tells me that there was a gap. And of course, then you realize a poorly regulated industry would amplify the problems. So the role is clear and critical for everyone in the room. My gratitude to all of my fellow speakers. I hope you guys had a good workshop. We had, I think for the first time, new topics that were added to the workshop. And any questions?
One question, sir. Good afternoon.
Good afternoon.
Just quickly, I don't know if it was said before, but I know UE has ATSU, but are there any publicly accessible addiction treatment services available, through either the regional health authorities, the individual health departments, you name it, that, any person who needs help can actually access?
So there's a difference. You have to think about addiction services in two ways. Let's simply put it inpatient and outpatient. Yes, outpatient services exist. So you would have heard from our representatives from the NCDA that there's a presence in most of the parishes. However, I would also tell you that with the level of use, similar to what Dr. McCleary mentioned in the prisons, the gap is still pretty wide because we just don't have enough persons with the expertise. Just to give you guys an idea, I mentioned it in my lecture last night, but in Jamaica, we have 45 psychiatrists. Now, psychiatrists are addiction specialists to some degree. Of course, you can subspecialize in addiction medicine or addiction psychiatry and become even more of an expert. But we are trained to manage addiction. But in a population of 3.3 million, 45 psychiatrists is woefully short because WHO mandates that you should have at least 1 per 10,000 population. By our current numbers, we're at about 1 to every 90,000 or 95,000. And if I take it even a step further, we have 45 psychiatrists, 38 of them live in St. Catherine and Kingston. 6 or 7 of them are living in the other 12 parishes. Let's take it another step further. We got 800,000 children out of the 3.2 million people in Jamaica, and we only have 4 child and adolescent psychiatrists. That's 1 per 200,000. And at least 2 of them are about to retire. So what it tells you is that while we can have the physical infrastructure, even if we had that, it needs to be in tandem with the expertise. We need more persons who are willing to train and do this. And to be quite honest, if you ask most psychiatrists don't like addiction because it's one of the most hardest things to treat. In fact, the studies are clear. 1 in 3 will never get better. 1 in 3 might get better. 1 in 3 will relapse. That tells you that maybe about 30% of people with addiction will actually beat addiction. So with that kind of numbers, it can also become vicariously hard for people to continuously treat persons who in their mind may not be moving anywhere because, sometimes we look at medicine as a problem, you fix the problem, move on. But with addiction, it's never like that. It's a problem that continues to remit and relapse. And so we need persons who are willing to do that. And that can be a challenge sometimes, yes? So in short, currently we have 1 6-bed inpatient service at UE. In the public system, I suppose outside of UE, anybody who goes for substance use treatment, there's no hospital that offers that service in particular. You might get admitted because you have a dual diagnosis and a substance use disorder. But to go to a particular place for acute detox followed by medium to long-term rehabilitation, University Hospital is the only place that has that service. Now, how can 6 beds move the needle? I hope that answers your question. Yes,
sir, it does, but it does sound like there's quite a bit of a systemic deficiency that need to be addressed to really holistically even begin to address the problem.
Yes, you're 100% right, which is why, today's workshop was also inclusive of many stakeholders. And it's not by mistake that we have persons from NCDA, DCS, university, all participating today, because we realize that this is an issue or a message that needs to be it needs more messengers, and I suppose that's what today's workshop helps to do. Thank you for your question.
Oh, never mind.
Keep going where we are, especially with the lack of access to care and so on. For me, in public health, the prevention and promotion is always my thing. What are we going to do to ensure that another generation of adolescents don't get introduced to cannabis research? That is my thing. What is the intervention that we're going to do in every primary school, every high school to get the message out and what the schools are going to do? That's where I'm at.
Yeah, I think you find you have a lot of people in this room and in this forum with a similar viewpoint. To be quite honest, guys, even discussing this topic is good and bad. It's good in the sense that we're creating some level of transfer of knowledge, but we also have to ask ourselves, how did we get here? Because the truth is that there could have been opportunities in and along the way to learn from the experiences of what other countries are going through. I'll tell you, when I wrote that drug driving paper a couple of years ago, I was looking at literature from 2010 in Colorado and Washington when they did their legislative reform, and they reported that within the span of a year, that having legalized, they could report those three major findings: increased cannabis-related accidents, impairment, and road fatalities. But when other countries now don't take the opportunity to think, well, what can I learn from the experiences of others, then we end up where we probably end up. Because if you go and look at our most latest Road Traffic Act amendment, it speaks heavily about driving under the influence of alcohol. But do you know what's in the Road Traffic Act for ganja-related activities? Anybody knows what happens if you're caught with a spliff in your mouth or you're thought to be driving under the impairment? What's your penalty? How much? My gosh, I wish. The penalty is 10,000 Jamaican dollars, and that's it. You go to other countries that have enacted the law, they realize, but hold on a second, we're going to take away your license for a year. You're going to have to do a drug rehab program or probation for another year, and we're going to charge you at least $2,000 US. But you know what 10,000 Jamaican dollars is right now? $60. Most people would just put that in their mouth and say, oh, officer, hold up, move on. You understand? So in other words, even our own legislation with regards to drug driving can be looked at, yes? So it takes that holistic type of approach. Thank you for your comment. Any other questions?
I have a question.
Yes.
It was the projection of the loss of human resources in the addiction and so on and psychiatric care. And so my question is, we as you said, learn from other countries. We have other countries who have successfully implemented some sort of addiction or rehabilitation programs, and they're training persons and retaining personnel. So my question is, what have persons at the University of the West Indies done to sort of encourage training of these persons, encourage them to go into the addiction, rehabilitation, specialty, even though it's not light, but what best practices could we use to encourage these people and to help build resource here in Jamaica?
If I answer this question, I'd have to answer it from, I'm trying to think how I should answer, whether from a personal viewpoint or from a professional viewpoint. I don't have any data to support the answer that you're asking. But what I can tell you is that from our training at university, we're very purposeful of including addiction treatment as part of our training over the 4 years or 5 years that you would spend in the program. So for those who do the psychiatry DM, you come out with management style for addiction second to none. So that's not the issue. The issue I think that probably has to be looked at is how much will be enough to service the gap? Because if I give you the figures of how much psychiatrists we have at the moment, but I also tell you what the gap is, you're going to need at least close to 300 more psychiatrists. And where are we going to get those persons from? In other words, what can be given to help facilitate that?
Right. But then, I mean, if we're gonna have more seats.
You look at what?
Opening more seats for trading for sure. Program and the goal is still.
That's a good point. That's a good point.
But then if Western Jamaica has such a deficit, why are we not looking to establish?
It's not that they're not looking. Remember also when you think about persons who would choose a subspecialty, for example, or a particular area of specialization, there has to be a motivation as well to do that. Yes? So I can't exactly tell you what the reason is, why or why not. I can tell you that maybe there's more research needed to look at why persons aren't considering it from even before you finish your medical school training. And I'll tell you, you bring up a point because it now has me thinking. Usually when I do a lecture for the medical students, one of my lectures is on the impaired physician. Do you know that the substance use rates or the initiation of substance use issues for persons who are in the medical field do not start after you graduated? They actually start while you're in medical school. So maybe in a way also it kind of makes you think about, from an earlier level, how motivated are a person really in doing psychiatry, or even better, addiction psychiatry or addiction medicine, yes? But you raise a very good point, but that is a point that I think persons have to be inclined to wanting to follow. It's not a very popular. Yeah.
Because you can set to say that because they're reading St. Anthony as they're trying to bring clarity to what is about people. I mean, right now, yes, I must leave so you can do that. You have to incentivize persons.
So, everyone, just to round up this session, I want to thank you all for coming out to the workshop. For all of those persons that made it in person, very happy to see you guys. For those that couldn't make it in person, I hope you were able to join us remotely, and the experience has been good for you. But certainly, if there are any questions for any of the lecturers or so on, feel free to reach out to Miss Candice, Miss Prince, and she will forward the questions to us. And certainly we will respond to them in very prompt manner. Yes? Other than that, I want to wish everyone a good weekend. And thank you again for joining us today. I appreciate it.
Thank you.
Thank you, Doctor. All the best.
Thank you.
Thank you, Dr. Lawani.
Thanks so much, Dr.
Again, I guess next year, featuring.
Which country?
Yeah, I was.